Okay, look like the live stream is up. Let's just check and make sure that we're in the right Zoom room. Okay, look good. Sergeant, will you begin your recording? According to the computer started.
Cloud has started.
Thank you. Good morning. Welcome to today's New York City Council remote hearing on the health jointly with the subcommittee on COVID recovery and resiliency. At this time, will all panelists please turn on your videos? I repeat, all panelists, please turn on your videos. Thank you. To minimize disruption, please place all electronic devices to vibrate or silent mode. Thank you. If you wish to submit testimonies, you may do so at testimony@council.nyc.gov. I repeat, testimony@council.nyc.gov. Thank you for your kind cooperation. Chair, we are ready to begin.
Councilmember Moyer.
Can you hear me? Good morning. Good morning, everyone. I'm Councilmember Francisco Moya, chair of the Subcommittee on COVID Recovery and Resiliency. I'd like to start by thanking my co-chair for this hearing, Councilmember Schulman, as well as my colleagues for being present today for this very important hearing. We are here today to discuss the current state of the COVID-19 pandemic as it pertains to health, the city's response, and looking forward. But before we begin, I'd like to recognize that we've been joined by Council members Arreola, Ayala, Barron, Brannan, Felice, Hudson, Narcisse, Yeager. I believe that's who I can see right now on the list. If I missed anyone, we'll come back to you. It's been almost 2 years since COVID-19 swept across our city, turning New York, and more particular, my district in Queens, into the epicenter of the pandemic. This pandemic has had a tragic impact across the world, and I've seen firsthand how the communities we serve were devastated by death, sickness, hunger, and unemployment. I remember clearly the lines along Elmhurst Hospital, having to jump on calls to address the hospital's and my community's immediate needs, personally securing and dropping off more than 120,000 masks and protective gear for Elmhurst Hospital staff at the height of the pandemic, because back then these supplies were limited for our frontline workers. The desperation in so many families, including a young constituent who was orphaned and whose family could not afford to bury their loved one, it's what led me to fight for and securing the emergency burial fund for New Yorkers, regardless of immigration status, long before resources came in from the federal government. Food insecurity was heightened and devastating. We had to fight to secure $25 million in funding for emergency food providers. And if you stop by the weekly food pantry I'm at on Saturdays in East Elmhurst, you will see that the lines still remain long. I can tell you how we had to pressure the previous administration to give us data so that we knew the infection rate, to prioritize testing and vaccines. I can give you countless examples of what we sent over to the previous administration. That was clear that the urgency needed for resources did not match the speed at which COVID hit us, especially in my district and the communities that I represent. The pandemic has exposed long-lasting issues with housing, healthcare, and employment, which left our city's residents vulnerable to the virus and the shutdown. As we move forward from the COVID-19 crisis, we must acknowledge that those inequalities remain, and we must make a commitment to truly addressing them as we move forward. This includes improving access to healthcare, particularly primary and preventative care, improving vaccination rates, particularly for the vulnerable populations, and working to remove barriers to access. One consistent barrier has been the language access. The ability to communicate in English can be an enormous barrier for the LEP communities when it comes to accessing critical city services and information. And while the city struggles to provide adequate language access on a normal basis, the COVID-19 pandemic has really heightened and amplified how critical timely language access is to New Yorkers. For example, public outreach and messaging in languages other than English were received by LEP New Yorkers at a consistently delayed pace, if at all. The city has also had difficulties in supporting the language access needs of immigrants across the city in making funeral arrangements for their deceased loved ones, as many non-English speaking families struggle to navigate the system and were subjected to price gouging. Additional language access issues were raised in the New York City Test and Trace program, and immigrant families in particular were targeted for rumors and misinformation. We now find ourselves entering year 3 of this pandemic, and these issues continue. This is unacceptable. The city should have done better, and the city must do better. The pandemic is long from over as variants of the virus continue to emerge and threaten New Yorkers, our business, our economy, and our way of life. We need to double down on the work now to ensure that we are, at the very least, able to communicate with all city residents. I want to thank Chair Shulman again, as well as the Committee of Health for joining our hearing today. And I also want to thank the committee staff for their work on this issue, the committee counsel, of course, the finance analyst, and of course, all the staff members, Herbani, Sarah, Lauren, my chief of staff, Megan, and Carolina as well. And with that, I want to turn this over now to my co-chair, Councilmember Shulman. Thank you.
Thank you, Chair Moya. Good morning, everyone. I am Councilmember Lynn Shulman, Chair of the Health Committee. I'm very excited to be chairing my first hearing at the City Council, and I would like to thank Councilmember Moya for co-chairing this important hearing with me today. I also want to thank and acknowledge my colleagues on the Health Committee who are joining us. Councilmember Moya already mentioned the members who are here, but I do want to acknowledge the ones that actually are on the Health Committee with me, which are Councilmember Feliz, Areola, Hudson, Barron, Yeager, and Narcisse. I also want to acknowledge Councilmember Gail Brewer has joined us, Councilmember Richardson Jordan, and I know I speak for the entire committee when I say that we are energized and ready to address the crucial task of overseeing the health of all New Yorkers as we check in on the current and future state of the COVID-19 pandemic. More than anything, New Yorkers are exhausted. This pandemic has disrupted our lives for 2 years now, disrupted family and social gatherings, disrupted our business communities, disrupted our children's schooling, and disrupted our access to healthcare. According to the Centers for Disease Control and Prevention, by June 30th, 2020, an estimated 41% of American adults had delayed or avoided medical care, including urgent or emergency care and routine care. Not surprisingly, these delays were not experienced equitably. Avoidance of urgent or emergency care was more prevalent among Americans experiencing poverty, unpaid caregivers for adults, persons with underlying medical conditions, Black adults, Hispanic adults, young adults, and persons with disabilities. In some cases, the very same communities that have experienced the pandemic more severely have also been more vulnerable to delays in their health care. Delays in 2020 were even prevalent among non-elective patients, such as people diagnosed with cancer. 79% of patients in active treatment for cancer reported a delay in their health care. Overall, 1/5 of all cancer patients and survivors surveyed reported concerns that their cancer could be growing or returning due to their challenges in obtaining health care. Additionally, some cancer clinical trials where patients can receive innovative therapies have been suspended, and organ donations and availability are on the decline. Even today, 2 years into the pandemic, medical providers are still concerned about delays in care. Recent reports have found that as of spring 2021, more than 1 in 10 adults chose to delay or not seek at least one type of care in the previous 30 days due to concerns about coronavirus exposure. And nearly the same percentage of parents delayed or forwent care for their children for the same reason. As many of you know, I was diagnosed with breast cancer while I was on the campaign trail for City Council. I am very thankful and grateful that I was able to receive the care that I needed. American adults had delayed or avoided medical care, including urgent or emergency care and routine. As many of you know, I was diagnosed with breast cancer while I was on the campaign trail for City Council. I'm very thankful and grateful that I was able to receive the care that I needed when I needed it. But my experience has left me deeply concerned that others have not been so lucky. I have spoken to fellow cancer patients and survivors who have expressed to me that their surgeries have been delayed, that their radiation or therapies are backordered because of supply chain issues, or that they are unable to see their doctors for routine follow-ups. This is not acceptable. The city needs to be doing everything in its power to give New Yorkers the confidence and faith to return to their healthcare providers and to seek care before they're in a state of emergency. Beyond the disruption to our lives, COVID-19 has fractured and polarized our communities and caused record high levels of burnout and mistrust of government and public health entities. It is our duty as public servants to rebuild trust and bridges and to do what we can through credible messengers and community leaders to instill within New Yorkers hope and faith that their political and public health leaders are fighting for them. I'm confident we can get there if we all work together. I want to thank the administration that has worked so tirelessly over the last 2 years for the city that we all love so much. I also want to thank Chair Moyer and my colleagues on the Health Committee and express how excited I am that I can be working with all of you. I also want to thank the committee staff for their work on this issue. Committee counsels Harbani Ahuja and Sarah Liss, policy analyst M. Balkin, and finance analyst Lauren Hunt. I also want to thank my chief of staff, Fasia Klass, who's been very instrumental in helping with this. I will now turn to the committee counsel, Harbani Ahuja, who will go over some procedural matters. Thank you, and I look forward to a great hearing.
Thank you, chairs. Before I begin, I just want to also acknowledge that we've been joined by Councilmember Velasquez. My name is Harbani Ahuja, and I'm counsel to the Committee on Health and the Subcommittee on COVID Recovery and Resiliency for the New York City Council. Before we begin, I want to remind everyone that you will be on mute until you are called on to testify, at which point you will be unmuted by the host. I will be calling on panelists to testify, so please listen for your name to be called, and I will be periodically announcing who the next panelist will be. For everyone testifying today, please note that there may be a few seconds of delay before you are unmuted, and we thank you in advance for your patience. All hearing participants should submit written testimony to testimony@council.nyc.gov. At today's hearing, the first panelist to give testimony will be representatives from the administration, followed by council member questions, and then members of the public will testify. Council members who have questions for a particular panelist should use the raise hand function in Zoom, and I will call on you after that panelist has completed their testimony. I will now call on members of the administration to testify. Testimony will be provided by Dr. Dave Choksi, Commissioner of Health. Additionally, the following representative will be available for answering questions: Dr. Ashwin Vasan, Senior Public Health Advisor and Incoming Health Commissioner. Before we begin, I will be administering the oath. Dr. Choksi and Dr. Vasan, I will call on each of you individually for a response. Please raise your right hands. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee and to respond honestly to council member questions? Dr. Choksi?
Yes, I do.
Thank you. Dr. Vasan?
I do.
Thank you. Dr. Choksi, you may begin your testimony when you are ready.
Thank you very much. And good morning, Chair Shulman and Moya and members of the committees. I'm Dr. Dave Choksi, 43rd Commissioner of the New York City Department of Health and Mental Hygiene. As you heard, I'm joined today by my colleague, Dr. Ashwin Vasan, Senior Public Health Advisor to the Mayor and the city's incoming Health Commissioner. Thank you for the opportunity to testify today and provide an update on the city's COVID-19 work. We're looking forward to working with your committees as we strive to promote and protect the health of New Yorkers and advance health equity in New York City together. I'll speak a little bit about looking back and then looking ahead. To say this has been a challenging 2 years would be an understatement, and I'd like to take a moment to acknowledge the collective trauma we have all experienced from this pandemic. The city has lost lives, livelihoods, and with each new wave, some have lost hope. Yet we are once again on the other side of a wave, this one due to the Omicron variant, and there is a new horizon ahead and a new cause for hope. We are seeing an average of less than 800 cases per day as compared to an average of over 40,000 at the peak of the Omicron surge. And our other indicators, such as hospitalizations and deaths, continue to decline. We must always remember that these data aren't just numbers. These are people, our family, our friends, our neighbors. In December, Mayor Adams announced a 6-pillared plan to combat the winter surge due to Omicron. Further increase vaccination rates, support hospitals and congregate settings, rapidly increase access to COVID-19 testing, slow the spread, for instance, through distribution and promotion of high-quality masks, scale up equitable access to treatment, and reopen schools with the Stay Safe, Stay Open strategy. I'm proud to say that we have executed on each of these pillars, and this work was instrumental to the continued decrease in COVID-19 indicators, saving lives even as our economy continues to reopen. I wish I could definitively say the worst is over. I know you're tired. I'm tired too. Right now, we need New Yorkers to stay vigilant and keep taking certain precautions to help protect our communities and particularly the most vulnerable New Yorkers. Time and time again during this pandemic, New Yorkers have done what's needed to slow transmission, even when it was incredibly hard and often painful. In spring 2020, this looked like staying home and putting all non-essential activities on pause. During subsequent waves, this meant hybrid school and work, dining only outdoors, getting fully vaccinated in order to partake in certain indoor activities, and delaying or reshaping major life and family moments, such as weddings and funerals. But we've taken these actions to protect ourselves and others, particularly those who could not work or learn remotely, those youngest New Yorkers who are still unable to get vaccinated, and those who are immunocompromised and thus at high risk for hospitalization and death. And as the science evolved, so have we. We've been flexible and I hope thoughtful and imaginative in how our city can function under great duress. And this shows that we collectively share some core principles, that we are resilient, that we care about our families, we look out for our communities, and we believe in science. And though there is still more to be done, I'd like to take a moment to acknowledge all we've accomplished. Through our place-based efforts in communities, our staff and community partners have reached millions of New Yorkers with COVID prevention information and resources via more than 24,000 outreach events and knocked on over 1.7 million doors. Our community partners are a major reason that over 60% of first and single vaccine doses have been administered to Black and Latino New Yorkers since July of 2021. This work is bolstered by members of our public health, a new partnership between the Health Department and New York City Health and Hospitals, or H&H, to expand and strengthen our community-based public health workforce and infrastructure and promote health equity for the communities hit hardest by the COVID-19 pandemic. Through the H&H Test and Trace Corps, millions of tests have been conducted, including those in schools, and self-test kits have been distributed on the ground in the community. And the Health Department has worked with congregate care settings, schools, and businesses to address clusters of cases and provide tools to help them control the spread of COVID-19 during surges, such as those due to Delta and Omicron, and in times of lower transmission as well. And thanks to our cross-agency healthcare provider and community partner efforts, about 6.4 million New Yorkers are fully vaccinated as of today, including nearly 87% of all adults. If you had told me a year ago that we would achieve that level of vaccination, I would have said that it was my greatest hope, but that it would be extraordinarily difficult. Now, with almost 17 million total doses administered, including over 3.6 million vaccinations administered through our city-run sites and mobile infrastructure, I think of the relief this protection has brought to so many New York families, including my own, and I'm so grateful. Our historic vaccination campaign has saved tens of thousands of lives and prevented even more hospitalizations. This is, to put it simply, a monumental achievement for public health and for our city. Over the past 2 years, we have worked hand in hand with our sister agencies, elected officials like yourselves, community and faith groups, and business, healthcare, and social service leaders to break down silos and reimagine government and private sector partnerships, all with a shared goal: to save lives, prevent suffering, and ensure equity for our fellow New Yorkers. Now, please allow me to turn to looking ahead. We have more to do. Even as we contend with COVID-19 as a more manageable risk, public health protections will remain critically important, particularly for those who are most vulnerable. To put it another way, living with COVID cannot mean ignoring that too many continue to die from the virus. We need all New Yorkers to get their booster shots to stay up to date with their vaccine regimen. This is how we get ahead of future variants of concern and prevent additional hospitalizations and deaths. We also need to urgently increase vaccination rates among our oldest and youngest eligible New Yorkers. Children ages 5 to 12 are only 41% vaccinated, as compared to the overall rate of 77%. We have worked extensively to increase these rates, but we know that vaccine confidence remains low in many communities, and misinformation is rampant. We are working to do more to combat misinformation and build trust through our partners, through media campaigns, through community healthcare providers, and of course, through elected officials like all of you. We need your help encouraging New Yorkers, particularly those with children or older family members, to get everyone in their household vaccinated now. As a reminder, people can go to nyc.gov/vaccine finder or call 877-VAX4-NYC to find a vaccine. And all New Yorkers, especially parents with questions or concerns, should call 212-COVID-19 to talk to a nurse or public health expert about the vaccines. And in the spirit of meeting people where they are, our teams remain on the ground in the community and also making calls to New Yorkers to help them make appointments, encourage sign up for our in-home vaccination program, and educate people about vaccines. In addition to increasing vaccination rates and ensuring all New Yorkers stay up to date with booster shots, we want to make sure that people are aware and able to access new treatment options. These new treatments help people feel better faster and also help keep people out of the hospital. But I want to be clear, treatment is not a replacement for vaccination. We still need New Yorkers to get vaccinated to prevent transmission and the worst outcomes of COVID-19. But now they have options for treatment if they do contract the virus. One option is monoclonal antibody treatment, which is available to people aged 12 and older who test positive, have mild or moderate symptoms for 10 days or less, and are at high risk as well. The second, newer treatment option is antiviral pills. There are 2 pills currently authorized and available to people who test positive, have mild to moderate symptoms for 5 days or less, and are at high risk for severe illness. Through a city partnership with Alto Pharmacy, these pills will be delivered same day for free to your door. As with so much else during our COVID response, we've taken an equity-centered approach here. In addition to working with providers of color and federally qualified health centers to ensure they're aware of and utilizing this service, the deployment of same-day home delivery eliminates barriers such as not living near a pharmacy or having time after work to go pick up the prescription. And it ensures that people in communities most at risk for severe illness from COVID-19 have access to this vital medication. And we've heard rave reviews about the service. For instance, one patient who was also undergoing treatment for cancer was grateful the medicine came to her door. She wasn't feeling well and didn't have anyone to go to a pharmacy on her behalf. Treatment works best the sooner you begin, so it is important to get tested right away if you have symptoms or were recently exposed. If you test positive for COVID-19, talk to your provider about treatment options. If you don't have a provider, you can speak to an H&H clinician by going to expresscare.nyc or by calling 212-COVID-19. And of course, I would be remiss if I did not mention the concurrent parallel pandemics that we can continue to address. In addition to COVID-19, the city is experiencing multiple health crises, including those related to mental health, chronic disease, drug overdoses, racism, and loneliness and social isolation. I'm proud to say that even with the demands of COVID response, the city and the health department have been undertaking work to address these parallel pandemics. In October of 2021, the New York City Board of Health issued a resolution on racism as a public health crisis, directing the health department to develop and implement concrete priorities for a racially just recovery from COVID-19, as well as other actions for the short and long term. For example, our Coalition to End Racism in Clinical Algorithms tackles the pernicious ways that racism affects the quality of healthcare for people of color. Additionally, in November, we announced that the first publicly recognized overdose prevention center services in the nation have commenced in New York City. In the short time that our partner providers have been operating the OPCs, over 100 overdoses have been averted. Mayor Adams has already taken bold steps to address chronic disease through access to healthy food and expanding lifestyle medicine services, driving home the importance of an upstream, prevention-focused approach where government helps make the healthy choice the easy choice. This is a very high-level overview, and we look forward to having the opportunity to talk more about these efforts in the future. But hopefully it gives a sense of the immense breadth of our work and the urgency, conviction, and innovative spirit with which we must take on these challenges. This is a pivotal moment for public health, and this pandemic has highlighted the fact that health is not just about what happens in a hospital or doctor's office. We've learned time and time again that we need healthy, resilient communities before crises like COVID-19 strike, so we can respond, heal, and recover as quickly as possible. The holistic view of health that we, the health department, take across all of our work is fundamental to ensuring that all neighborhoods in New York City are able to not just recover from this pandemic, but also thrive. Finally, as I've said before, there is no economic recovery without investment in public health. We must remember that even when the painful memories of shuttered businesses and schools start to fade. And the time is now for massive and durable investment in our public health infrastructure, just as we think about investment in roads and bridges at all levels of government to bring about a just recovery for all New Yorkers. Again, the department looks forward to partnering with all of you on this work as we forge a healthy and equitable path forward. Dr. Vasan and I are happy to take questions. Thank you so much.
Thank you, Commissioner. I'm going to now turn it over to questions from Chair Shulman, followed by Chair Moya. Panelists from the administration, if you could stay unmuted if possible during this question and answer period, we'd appreciate that. Chair Shulman, you may begin.
Thank you very much. Dr. Chokshi, I also want to thank you. You know, we're experiencing the worst public health crisis of our lifetime, and I want to thank you for your service in getting us to this point. With that, I have some questions that I would like to ask, because I think that as much as we've done well, we can do better. As we continue to see declining rates of COVID-19 cases, hospitalizations, and deaths, what is the most important message we can provide to New Yorkers as they continue to navigate life with COVID-19?
Thank you so much, Chair Shulman, and thank you again for the partnership. And I know it's going to be an important chapter for public health in our city under your leadership of the Health Committee. With respect to your question, the most important message is a combination of ensuring that people know that COVID remains a risk, and that we do have to continue taking certain protections, particularly the fact that we need more New Yorkers to get their booster doses. We need more New Yorkers, particularly younger New Yorkers, to get vaccinated. And if people are at higher risk, for them to continue taking other public health protections, whether it's wearing a high quality mask in indoor settings, or ensuring that that people continue to get tested if they experience symptoms. These are things that we now have over 2 years of experience in doing, and that we have to maintain a focus on, because even though COVID may be a more manageable risk going forward, it remains a risk, and particularly so for more vulnerable individuals. The other piece of this is for us to convey that there are so many cascading effects of COVID-19 beyond the direct effects of the virus, whether it has to do with what you have highlighted through sharing your personal story and ensuring that people are visiting their primary care doctors for screening for cancer or blood pressure or diabetes, or some of the initiatives that this administration and particularly that Dr. Vasan will be spearheading to address mental health challenges as well as substance use disorders. This is something that we have to redouble our efforts on as we hopefully continue to emerge from the pandemic.
So while we're moving forward with this piece of it, how is the Department of Health and Mental Hygiene preparing for the next variant? There are scientists who say that the new variant is right around the corner and it could be worse than Omicron. And so while we're going down this path, how are we preparing for the challenges of the future?
Thank you so much. This is another important question. I'll start and turn to Dr. Vasan because he is also instrumental to the planning here. But let me start just by saying that we are prepared for future variants as well as additional waves of COVID, although I hope that we won't suffer nearly as much as we have in the past. We're prepared because we maintain robust surveillance capacity. We do this through a combination of ensuring that we are able to track cases, hospitalizations, and deaths, just as we have over the past 2 years. We also have specialized genetic testing that allows us to know when specific variants are here in New York City. That's how we were able to keep track of Omicron as it became the dominant variant over the course of December in New York City. We have our testing and vaccination infrastructure in place. It will remain nimble and will be able to scale up as needed. And importantly, we are investing in the place-based approach to health and health equity that I described, partnering with community-based organizations through things like the Public Health Corps, partnering with community health centers like federally qualified health centers. This is fundamentally important to have the infrastructure to be able to respond quickly to any health crisis going forward, whether it's another wave of COVID-19 or the next public health emergency. With that, I'll turn it to Dr. Vasan to see if he has anything to add.
Thanks, Dr. Choksi, and thank you to the chair and all the members for inviting me here. It's an honor to be amongst you and with you, and I look forward to our partnership over the coming weeks, months, and years. There isn't much to add to what Dr. Choksi said, but just I'll give you my perspective coming in from the outside into this, what I can only characterize as a formidable response. The scale of what's been built by the health department and by our public health apparatus in the city is really impressive. And we're in a position where we are capable of responding to emerging threats in a way that meets the need of the moment, combined with what New Yorkers have done to increase their protection against any new variant or emerging threat coming down the pike. And again, I share Dr. Choksi's hope that that's not the case. And so, I'm confident that we have the infrastructure and the programs and the systems to both respond to in terms of place-based approaches, but also in terms of scale, flexibly standing up and taking down testing sites, flexibly standing up and taking down vaccination capacity as needed, and keeping our schools amongst the safest places in our city. I think we are incredibly prepared, and that's a testament to the work that's been done over the last 2 years to respond to this pandemic.
Thank you very much. Just to continue, one last question in this little thread is, as more and more people are testing at home, how are we keeping track of that? Somebody can test positive and have some new variant that we're not clear on because there's no database to keep track of these. So I want to see how you are proposing to deal with that.
Thank you, Chair Shulman. This is also an important question that we've been tracking and thinking through. The starting point is that we have one of the most robust testing infrastructures in the entire world in New York City. This is both laboratory reported, what are called molecular tests or PCR tests, as well as laboratory reported antigen tests. Those are the data that we report on the health department's website and that allow us to maintain surveillance at an extraordinarily rich level to understand what's happening, not just on a citywide basis, but also in communities. We have had to adapt, as you're pointing out in your question, as rapid test kits become more prevalent. And this is a good thing. This means that people are able to test more quickly, which is particularly important to access treatment, as I've alluded to, but also because it means that if someone does test positive, they're able to isolate more quickly. Those are the most important things when it comes to test results from those rapid test kits. And provided that we continue to maintain the high level of other testing infrastructure that we now have, we have a sufficient sample for us to be able to track the spread of the virus, including the spread of new variants through the more specialized genetic testing that I've alluded to. So we're always trying to strike the balance. We want more convenient testing through those home rapid self-test kits while maintaining some of our more robust testing infrastructure for surveillance purposes.
Okay, thank you. I want to acknowledge that we've been joined by Councilmember Brooks Powers. DOHMH data has shown that COVID-19 hospitalizations and deaths have disproportionately impacted those who are Black, African-American, Hispanic, Latino, older, and/or those who are living in high poverty neighborhoods and/or the Bronx. Although the data doesn't capture it, we also know that other communities have been disproportionately impacted, including disability, immigrant, homeless, religious, limited English proficient communities, and lesbian, gay, bisexual, queer, questioning, transgender, gender nonconforming, and non-binary communities. How is the city continuing to utilize an equity lens to address COVID-19 concerns?
Thank you so much. This is central to our COVID-19 response, is placing equity as one of the most important pillars with respect to everything that we're doing, whether it has to do with testing or vaccination or public messaging. We elaborated our equity action plan, which seeks to advance equitable policies and practices in our COVID-19 response. And it has 4 main prongs, which I'll just go over briefly. First is community engagement. Second is provider engagement. Third is access to resources. And fourth is data. I'll just say a little bit about each of them, and then I'm happy to answer more specific questions, Chair, as you guide us. First, with respect to community engagement, the way that I always describe this is that this is fundamentally about humility, about the health department and city government taking a step back so that we can take a step forward with respect to bringing equity to the forefront of what we're doing. This is why we have invested as much as we have, over $120 million flowing through community-based organizations so that they are the trusted messengers who have been working for years, in many cases decades, in their own neighborhoods, and who can help us with COVID response in a way that allows them to tap into the networks that we know are so important for an equitable response. Second, provider engagement. This is the partnership with federally qualified health centers that I've mentioned, but also all providers across the city. We've been doing intensive, what we call public health detailing efforts, which is sitting down with providers, particularly in our task force on racial inclusion and equity neighborhoods, ensuring that they know about the latest scientific updates, whether it's about vaccination or the new treatments, and making them available to the patients that they're serving. Third is access to resources. All of the language matters less than actually being able to channel investment in all of the ways that we have attempted to do, whether it's standing up physical infrastructure, a mobile vaccination site, or a dedicated brick and mortar testing site. and also distributing masks and our home test kits into the hardest hit communities. And the fourth part is data. In many ways, this is really where our response begins. It's the lifeblood of our response to be able to understand, as you pointed out, how the virus has disproportionately affected certain communities and to guide the various elements of our response based on that. We're one of the most transparent jurisdictions when it comes to the various ways that we are sharing our data by race, ethnicity, by age, by place, and we'll continue to evolve that approach to be able to meet our aim of equity in our response.
Okay, you are doing better than the CDC, I will tell you. I will tell you that.
Thank you.
According to the CDC, lesbian, gay, bisexual, and transgender persons are at increased risk for severe COVID-19 illness because of a higher prevalence of comorbidities. What is the city doing to meet the needs of this community and to improve data collection regarding COVID-19 and LGBTQTGNCENBY communities?
Thank you very much, Chair. And first, I'll just say that that I agree with your framing in this question as well as the prior one. Equity must extend to the communities that we're talking about, LGBTQ, as well as TGNC or transgender and gender nonconforming communities. We've tried to do this along those four avenues that I described earlier. But it starts with, again, making sure that we're drawing upon the long-standing relationships that already exist in this space, both between the health department and LGBTQ and TGNC leaders. For example, I know, as you are well aware, we have relationships through our HIV work that we've drawn upon during COVID response. This spans everything from town halls with groups like Housing Works, information sessions with several organizations that serve people who identify as LGBTQ and TGNC, as well as surging resources for Pride events during the summer of 2021. We're always happy, of course, to do more and make new partnerships in this vein, and we're happy to work with you and the council in doing so. But you asked more specifically about data as well. And I'll start by, again, just saying that we strongly agree that collecting information about both sexual orientation and gender identity, fundamentally, this is a part of health and healthcare. That's how we have to think about it. It's one of the reasons that we added questions about gender and sex assigned at birth to our city site scheduling app. And we're actively working to try to do this much more broadly, across routine healthcare. Although I will say that this requires collaboration with our state colleagues because much of this is under the purview and the jurisdiction of New York State for healthcare providers. Personally, I very much support this being a requirement for providers for vaccination as well as other services. And it's an area where we do have to continue to improve and evolve.
Well, I look forward to working with you on that. This is the next question. I'm not sure that you guys can answer this, but I'll ask it. It's well known that there have been issues with death certificates not listing COVID-19 specifically as the cause of death and instead list a related illness. This has led to barriers receiving burial assistance from FEMA. And in response, FEMA had loosened some requirements. Is the city aware of ongoing issues pertaining to acquiring or amending death certificates for these purposes?
Yes, thank you for this question as well. Let me just take a step back with you to recognize that this is something that is tragic at a time when a family is grieving their loved one. With respect to accessing burial benefits, with respect to having to navigate a system, in order to change or amend a cause of death on a death certificate. So. Not just as a health commissioner, but as a doctor, I really sort of understand why this is such an important issue and is so deeply felt by people. We are aware that this is an issue, although we don't necessarily have direct purview over it. We maintain death certificate records for New York City, but the causes of death, are filled out by physicians, by whomever the attending physician is at the time of death. And sometimes the way in which that is filled out means that COVID-19 is not appropriately documented on the death certificate. We have been working, with our colleagues at the Office of the Chief Medical Examiner, as well as our healthcare partners, to try to improve this, because we end up hearing about it from families who are trying to get copies of their death certificates from our department. And I'll be happy to follow up with some more specific information about ways that we have tried to facilitate improvement in that process. But again, I certainly understand why it's such a significant issue at a time of grief and tragedy for New York City families.
And I'm also concerned that hospitals may not want to admit to the fact that they had a lot of patients who passed from COVID. So that's something moving forward that maybe we can work on. Now, I want to ask, how are we as a city looking ahead and building a more equitable healthcare infrastructure? So there's a few parts to this. One, how are we prioritizing social determinants of health? How are we prioritizing primary and preventive care?
Thank you. This is one where I'll invite Dr. Vasan to share his vision and thoughts as well. But let me start with the fact that we are in such an important moment to address the very issues that you're pointing out. Mayor Adams has spoken eloquently about the need to move upstream to address all of the things that matter for the downstream health outcomes that doctors and the healthcare system end up seeing, whether it's chronic disease or mental illness or substance use disorder. And so our starting point has to be taking on those more upstream factors. So what does this look like? There are a few elements to the approach which I'd like to describe. First is the notion that we have to do it in a place-based way. We have to recognize that health is shaped by a multitude of factors that often are determined by neighborhood. This is sometimes summed up as the idea that one's zip code is at least as important as one's genetic code when it comes to health outcomes. That means that we have to redress the disinvestment that has occurred in so many communities, particularly communities of color, and also make sure that we are talking about food and housing and education in the same breath that we're talking about medicine and healthcare delivery. So the place-based approach is one sort of cornerstone. The second thing that I'll say is that we saw during the COVID-19 pandemic what happens when there is not sufficient investment in public health. And so we have to use this moment to ensure that we change that paradigm, that we invest in things like the Public Health Corps and our community partners, whether it's community-based organizations or faith leaders or otherwise, to ensure their readiness and a sufficient infrastructure to be able to deliver on what we have to do with respect to equity. And the final thing that I'll say is, again, to sound a note of humility. Although the health department has this awesome responsibility of trying to save lives and prevent suffering for the entire city, we also know that this has to be done in partnership with so many others across the city. And our role is to recognize that and to make sure that we are building those collaborations so that we can take on what are often very entrenched issues together. I'll turn to Dr. Vasan to see if he has more to add to that.
Thanks, Dr. Chokshi. Among the several things that Dr. Chokshi and I share is the fact that we're both practicing primary care doctors. And that's important because primary care really sits at the nexus of the clinical system, the healthcare system, and social determinants. Often we are the first to witness the health effects of longstanding inequities, social risk, and vulnerabilities that are structural in nature and that require a truly intersectional approach to their solutions. And so our responsibility as doctors who sit both inside of healthcare, but understand the limitations of healthcare in solving social vulnerabilities and social risk that impact health, is to use our position at the health department to raise up these issues, to drive partnerships across government, outside of government, with our community partners and with all of you, to solve for those things, because it does truly take an intersectional whole of government and whole of society approach to solve for some of these issues. And what are these issues? I mean, housing, public safety, quality of education, immigrant rights, and language access was mentioned earlier, access to fresh, healthy foods, transportation. These are all the building blocks of better communities, better and healthier lives. And the health department is in a unique position to align and to identify, to evaluate, and to drive coordination across those goals to solve for those health issues. But we certainly can't do it alone. And I look forward to, especially under this administration, which has said very clearly that it wants to drive, the de-siloing of government, the efficiency of government, collaboration, not only across agencies, but better collaboration between City Hall and agencies. I think we're at a unique moment where we can do quite a bit on the social determinants of health.
Thank you. I want to acknowledge that we've been joined by Councilmember Carlina Rivera. While many of those vaccinated and boosted are largely protected from the impacts of COVID-19, which communities remain at risk and what are you doing to support them?
Thank you so much. This is an important question that I think about all the time, particularly as we have made tremendous progress in protecting more and more people and communities thanks to vaccination. The ones that I remain the most concerned about are people at both ends of the age spectrum. The oldest New Yorkers who, in some cases, even when they are vaccinated, remain at higher risk for severe outcomes. Particularly if they have underlying health conditions or weakened immune systems. And so we have to continue to hold them in mind as we think about policies for the entire population. There are also some older New Yorkers who remain unvaccinated, and that has been a particular concern of mine that we have tried to address through direct outreach, through partnership with the Department for the Aging, and really trying to be as boots on the ground as possible through, for example, our in-home vaccination program to lower barriers of access as low as they can possibly go. On the other end of the spectrum are kids who are younger than 5. Thankfully, overall, kids remain at lower risk from the most severe outcomes of COVID-19, but low risk is not zero risk. And I can tell you, not just as a doctor, but also as a father of a 2.5-year-old, this is something that so many parents, continue to worry about. And we have to take steps to ensure that they are as protected as possible until they become eligible for vaccination, which I hope will happen sometime in April based on what we're hearing from the federal government. So it's those ends of the age spectrum. It's also people who remain unvaccinated in certain communities, whether it's by place or by race and ethnicity. I follow this data daily, and it's shared on the health department's website. And that data is what drives our action with respect to the grassroots efforts, usually done in partnership with community-based organizations to ensure that we are delivering messages through trusted messengers in the languages that are native for people to be able to access that information. And again, to make it as easy as possible, for people to get vaccinated. A final thing that I'll say is that beyond vaccination, we are in a different era because of the advent of these new COVID-19 treatments. And one of the things we felt so strongly about was this same day delivery, to be able to bring to people's doorstep these treatments that are highly effective. For every 20 people who are treated with one of the new oral antivirals or the monoclonal antibody treatment, we can avoid one hospitalization. So that means we have another very important arrow in our quiver that we have to make sure gets to the people who can most benefit from it.
You mentioned the in-home vaccination program, which I'm glad that you brought up because a lot of people don't seem to know about it. So how are you promoting that? How are you educating people that exists?
Thank you. And, we welcome any and all ideas, of course, as we continue to promote it. Thus far, it has been broadly promoted across all of our media and social media channels. We make sure that clinical providers are aware of it as well. Often people who are homebound or who have limited mobility will be getting healthcare for another reason. So we partner with, for example, visiting nurse services, home health agencies, as well as home-based primary care programs, either to supply them with vaccines so that they can vaccinate their own patients, or to make sure that they are aware of the city's in-home vaccination program so that we can actually get to them. We did, hear early in our booster campaign that people maybe weren't aware that they could get their booster dose through the in-home vaccination program as well. And that was a particular area, that we attempted to highlight through those various channels that I mentioned.
Maybe there are some other avenues that you can take as well. First, it comes to mind community boards and just getting word out. Us as council members can help with that as well. So I just wanted to mention that.
Thank you so much.
Are individuals who test positive still receiving calls from T2 with information about resources available to them if they need it, such as hotel rooms?
The short answer is yes, they are. We are changing some of our approaches to contact tracing as well as isolation and quarantine as we enter into a new phase in the pandemic. But our focus has been on ensuring that people, first of all, get tested as soon as they're experiencing symptoms, and as soon as they know they are positive, that they both are aware that they need to isolate, but also have the resources that they need to be able to isolate effectively, whether that's making sure that they have food or groceries, or when they need it, a hotel room to be able to safely isolate from family members or other people whom they may be sharing a living space with. So all of that does continue to occur. T2, which has done really terrific work, throughout the entire pandemic, has used a multitude of different channels, often phone calls, but also text messages, which some people are more comfortable, being in contact via those means. And so those approaches will continue to evolve as well.
Thank you. How is the city partnering with medical providers to give them information about city resources in the event that their patients contact them to report that they or a family member have tested positive?
Thank you for this important question as well, Chair. We are in constant communication with clinical providers across the city. We do it through a range of different ways. First of all, we have health alerts that are sent out anytime there are major updates to clinical guidance. We are able to blast that via emails, text messages, town halls and forums that are specifically targeted to clinical providers, as well as making sure that we're in touch with the leadership at the large health systems, safety net systems, and independent providers. We have a chief medical officer, Dr. Michelle Morse, who is particularly instrumental in organizing, that outreach with people, with clinicians across New York City. But beyond that, we take a very grassroots approach to this as well. We actually have teams that go out and sit with clinicians in their own offices to make sure they're aware of the most up-to-date scientific information, whether it's vaccination or the new treatments or changes in guidance, to make them aware of those developments and to answer any questions. We find that the way that clinicians can build trust with their patients often relies upon our having built trust with them. And we have a particular focus on doing this with providers who serve Black, Indigenous, and people of color, as well as providers who are in those task force on racial inclusion and equity neighborhoods. So those are ways that we have sought to make sure that our messages are broadly distributed, but with a focus on our equity imperative as always.
No, I appreciate that. And this is, this program is pretty robust. I'm going to ask, I understand that the monies, the federal monies for the T2 employees, the test and trace runs out at the end of April. Is there, what's being done to keep them either in place or have them do something else? I mean, what provisions are being made for when that money runs out?
Thank you, Chair. Please allow me to come back to you with a more specific response on this one. I will have to confer with our test and trace colleagues on some of the specifics here. But the broader answer that I can give is that this is part of the reason that the investment in Public Health Corps, which is community health workers, people who come from the communities that they are serving, is vitally important for the longer term. We're collaborating with health and hospitals on those investments in community health workers, and that's part of the long-term solution to the question that you're asking.
I appreciate that. I'm going to turn this over now to Chair Moyer for his line of questioning. Thank you very much, Commissioner. I appreciate both commissioners. I appreciate it.
Thank you, Chair Schulman. Thank you, Doctor, for being here. Always good to see a neighborhood guy going well. So I just want to focus my line of questioning on a couple of topics. I'm going to make it short because I want to give my colleagues an opportunity to ask some questions as well. I'm going to focus on language access, and then I'm also going to focus in on sort of the community based organizations that we've been working with. Look, as you know, Elmhurst Hospital, epicenter of the pandemic, we saw what was going on, large immigrant community here. For me, how is the city, looking back, how is the city now working to ensure that communities with historically less access to healthcare do not miss being vaccinated, but also how is the city reaching out to communities that have limited digital literacy, right? We saw that there was a lack of access to the internet, the digital divide. So how are you guys working that out, knowing full well that folks may not have smartphones, access to the internet? If you can just talk a little bit about that, that would be great.
Certainly, and thank you, Chair Moya. And I'll start just by saying that these are issues that I know that you care deeply about, that I'm also passionate about. I know Dr. Vasan is as well. And so although, we'll have sort of specific responses, I think the most important one that I can give is that we really welcome partnership, feedback, and your thoughts and collaboration for us to continue to meet this really important part of our mission. And as you alluded to, those memories of March of 2020, when I was making rounds with the infectious disease team at Elmhurst Hospital, those are seared in my memory forever. And it's part of the reason that these questions are so important, because it's a chance for us to redress some of what we saw, happened during those dark days in spring of 2020, particularly through vaccination, as you're pointing out in your question. We do have a number of efforts to ensure that all of our materials are available in the city's top 13 languages. I just want to list them out because it's very important to understand, the breadth here. It's Spanish, Simplified Chinese, Traditional Chinese, Russian, Urdu, Bengali, Haitian Creole, Yiddish, Italian, Polish, Arabic, Korean, and French. In addition to that, translation, there's also custom translation. This means it's actually performed by linguists for the main COVID-19 and vaccination materials. as well as all of the large-scale media campaigns, which are always done in a multilingual and multimedia way. We work with our community outreach colleagues to ensure that those materials actually get to the communities that we're serving. And again, this is a place where the health department takes a step back and empowers the community partners who, as you well know from your own district, have been serving these neighborhoods for decades and are in many cases the most trusted institutions in those places. You asked about digital literacy as well, because in some cases they may, the people that we're serving may not be able to navigate to a web page in the first place. This is why we've made sure that there is both a telephonic and in-person channel for so much of what we're doing as well. For vaccinations, 877-VAX4NYC, and there are interpretation services available, by calling that phone number. For anything else related to COVID, it's 212-COVID-19, and that means even the conversations with nurses or doctors that are facilitated through that phone number, will be aided by translation services too. The final thing that I'll say is that this is another area where we do want to tap into the healthcare infrastructure and all of the ways in which the existing healthcare infrastructure also serves communities for whom there's limited English proficiency or limited digital literacy. And in those cases, our goal is to make sure that healthcare providers have the information that they need, that they're aware of the various resources that the city provides, and that we empower them, to be able to take care of their patients as well.
Thank you. That's great to hear, because, in the beginning when we were rolling out the vaccine, most people didn't have access to the internet or to a computer, whether they were seniors or immigrants. Getting folks on the ground with the tablets in communities like ours, deploying them, that is an important step in the right direction in which we need to continue, because we know that, this isn't going away. So it's just really key for us to continue to have the boots on the ground with the information. It's good that you listed the number of languages in which it's translated. The other question is you touched a little bit upon this with the ethnic media as well, but also has the department worked with, not this Moya, but the other Moya, in doing messaging for the hard to reach communities in the city? And if you can just elaborate a little bit more on that, that would be great.
Yes, we have a deep and productive relationship, with Moya, with the prior commissioner, and I made it one of my first orders of business, in the initial weeks of this administration, to reach out to Commissioner Castro, who, as you know, is also a neighborhood guy, and made sure that we are partnering for the ends that you're describing. They have a particular expertise and history as well in terms of serving immigrant communities. And this is so important, again, for us to be able to work through, because particularly for undocumented immigrants, we know that fear related to accessing healthcare is a major factor. This is why we have to partner with community-based organizations, but also, the healthcare institutions that many immigrants are used to seeking care at, whether it's Elmhurst Hospital or Bellevue, where I take care of my own primary care patients. These are places where people know that they can seek care without fear, and for us to be able to, ensure that we have seamless collaborations with. We're also working with, the Mayor's Office of Media and Entertainment to ensure that we're producing videos in different languages for public outreach and messaging. We ourselves, meaning the health department, we have 6 contracted ad agencies we work with to develop media campaigns that, again, are all translated into those top languages spoken across the city. But beyond language access, and I know you, of course, understand this as well, it's also about cultural competence and cultural humility. certain messages land differently in different cultural backgrounds. We have to make sure that we are partnering with people who understand the nuances of cultural competence for different communities. And that's also, foremost in the work that we have done. I'll just point to a couple of collaborations that we've done with the Latino Film Festival, that's contributed to some of the vaccination videos that we've produced with an organization known as BRIC, B-R-I-C, which has also created multilingual PSAs, as well as collaborations with other organizations, particularly those that are serving the Orthodox Jewish population and other communities across the city.
Before I go to my next question, I just want to acknowledge that we've been joined by Councilmember Rivera and Councilmember Mealy as well. So just sticking with that, how is the city ensuring that the vaccination sites, the testing sites can be navigated by individuals who are LEP? And are there interpretation services on site? Is there signage in languages other than English there?
Thank you, Chair. Another very important question, and the answer is yes to all of the above. I know this because I've worked at our vaccination sites myself, and I've seen with my own eyes the ways in which we do try to make this more accessible. Signage in different languages is present. We have interpretation services through live interpretation for some languages. Usually someone's wearing a specific vest, that indicates that they are available for in-person interpretation. So many of our staff come from the neighborhoods that we're serving, and so that facilitates, our ability to provide it in that way. And when we don't have on-site interpretation services for a particular language, we're able to call upon it either telephonically or via video interpretation services as well. So all of those are present, across our testing and vaccination sites. But our culture is one of continuous improvement. So if there are specific areas where that's not being felt or delivered as well as it should be, we welcome any and all feedback to try to improve that service.
Well, you just walked into my next question, Doctor. So as we've heard in my office, and I've personally seen this, complaints from constituents about the lack of adequate language access from the city throughout this pandemic. Do the city agencies, does your agency have contracts with outside vendors to provide interpretation or translation services that engage with the vendors to discuss improvements? And if you get the complaints, do you discuss them with the vendor? Like, how does that relationship work? Because I'll tell you, if I get an H&H van out in my district, I have no problem. If I get a vendor's van out there, they don't show up on time. There's no information given to the people who are waiting outside. They may not have translation services there. We've seen long lines that have taken place there. And so it's two different types of services that we get. And I'm just trying to get to the fact of, like, how are we working with these vendors? Like, how do we make these choices here? Because we need to do better in that sense, because it's been a problem since we've started that.
Thank you, Chair Moya. Thanks for pointing it out. And if you're seeing problems, then we do need to improve. So that's the starting point. With respect to your question, yes, we do have contracts for translation and interpretation services with outside vendors as well. During the pandemic response, we both utilized those existing contracts as well as established additional contracts, because we have seen how important this is, particularly to address questions in a way that forges and builds trust. And we know that sometimes we're starting at a deficit of trust, with certain community members or with certain populations. And so this is fundamentally important for us to be able to surmount that mistrust. So we have those additional contracts, and through them, we're able to provide interpretation services in hundreds of languages. This includes American Sign Language, as well as all of the languages that are commonly spoken in New York City. In terms of the feedback loop that you're asking about, we do have regular communication with our contracted vendors. We take very seriously our responsibility for oversight and accountability, with those vendors. When there are issues or complaints that arise, we have additional conversations with them, escalating up, to their leadership and making it very clear that this is, part of their responsibility as part of the contract that we have with them. And I'll say that most vendors are generally responsive and willing to address any issues, but we want to make sure that we, do that quickly and channel it back in a way that you see that any problems that do crop up are being addressed in real time.
So look, I'd love to follow up with you on this, just because, we've had several complaints. I know I've reached out as well, so I'll talk to you offline about that.
Thank you.
Just moving on to the Equity Action Plan, which seeks to advance equitable policies and practices in the city's COVID-19 response by using a racial justice framework and population-specific strategies to better reach community members. Can you please provide us an update on how that plan is rolling out and what population-specific strategies is the department using?
Thank you so much for the chance to say a little bit more about our Equity Action Plan. So I had mentioned, the 4 pillars of that plan, which were community engagement, provider engagement, access to resources, and data. And these have really been the underpinnings for all of our pandemic response over the last 2 years. The department, even prior to my tenure as commissioner, had rolled out an initial version of an equity action plan, and then we updated it, particularly in the context of vaccination, with our vaccine equity strategy. And over the course of the past year, have really focused on ensuring that equity is part of what we hold ourselves responsible for, during the vaccine rollout. It's why we've invested over $125 million in community-based organizations, through work that T2, the Test and Trace Corps, had started, but also supplemented by what we call the Vaccine Equity Partner Engagement Program, which channeled additional funding and which we now aim to carry forward through the Public Health Corps, working with many of those same community-based organizations, faith leaders, and community health centers. So that is the arc of our work on equity. Ultimately, I'll say a couple of things. One is that we should look at the results. Ultimately, we can only declare success if we're seeing that we're reaching the people that we intend to reach. One of the data points that's heartening in this respect is that 60% of all first doses from July 15th, 2021 onward went to Black and Latino New Yorkers. A lot of this was because of the work that we did around community and provider engagement, as well as the vaccine policies and incentives that we rolled out in the latter half of last year, and which Mayor Adams has continued, and that has helped to ensure that people were far more protected during the Omicron wave than they would have been otherwise. But equity is not a static priority. This is something that we'll have to continue addressing going forward, both as part of COVID response, but also not missing the opportunity to learn the lessons of health equity when it came to the pandemic, and try to put New York City in a much different position for the long term as well.
And with that, how is the city been counteracting the anti-vaxxer movement and the misinformation that has gone on in our communities?
Yes, thank you, for this really important question. And again, I'll start by sounding the note that this is not something that the health department can do alone. We need your help. We need the help of people all across the city so that our science-based messages, they spread faster than the misinformation. And ultimately, they have to spread faster than the virus. That's how we're going to actually be able to to finally end the pandemic overall. Some of the ways that we're addressing this are that investment in community-based organizations and faith leaders, that I've alluded to, making sure that we are putting out our science-based messages. The best approach is to prevent misinformation from taking root in the first place. And that's why we've been very aggressive about ensuring that, we are broadcasting our messages, any changes based on scientific information, and doing as much outreach as we have. I mentioned in my testimony, we've done over 24,000 events. People at the health department have been working tirelessly to make sure that we help to get the word out. But we're not just doing it, through virtual forums or even physical town halls. We are getting out on the streets and, into buildings, into apartment buildings and other complexes. We've knocked on over 1.7 million doors to be able to do that. The last piece that I'll say is that we have developed a surveillance infrastructure for misinformation to be able to understand, the key elements of misinformation in real time as they are spreading, and channeling that back into our own messaging so that we're aware of, the messages that need to be combated, and doing that in multiple languages as well, because we know that misinformation can look different for different communities. So all of those are ways that we have attempted to fight back against misinformation. But again, we welcome, partnership from all corners on this particular issue.
And going with that, because you in your answer, you just touched upon what my next question was, but it still goes into the work with the community-based organizations. We saw that working with the CBOs, faith-based groups, advocates, to help educate, our community, was a really important step. How have you engaged with the CBOs that work with the communities that were hardest hit by COVID, including the Black, Latinx, immigrant, undocumented, homeless, the Orthodox, the disabled, the LGBTQ, and the elderly New Yorkers? Like, how has that come together to, get the message out?
Yes, well, this has been one of the most beautiful and heartening things to witness, as part of pandemic response, because there are so many dedicated community-based organizations, faith leaders, other groups who are more expert and more trusted in many of the communities that they're serving. I know you'll hear from some of them, later on in the hearing. I see their faces and names on the Zoom right now, and it brings a smile to my face just to know, that as our partners, they have been shoulder to shoulder with us, as part of pandemic response. So the ways in which, we've tried to empower and work with them is first by ensuring that we are channeling investment. We've worked with approximately 100 community-based organizations, specifically on building vaccine confidence across our communities, and allocated about $125 million to those community-based organizations, as well as our community health center network partners, the federally qualified health centers that I mentioned earlier. We do this in a way that is not just about investment, but ensuring that we're all reading off of the same sheet of music when it comes to science-based information, when it comes to making sure that we're talking about things that are relevant to the neighborhoods and the communities that we're serving. I was out in Brooklyn a few weeks ago with one of the organizations that we partnered with, Brooklyn Community Services, and they were handing out high quality masks, KN95 masks, in the neighborhood that they've been serving over the course of the pandemic and many years before. And what struck me was not just that people already knew, the workers who were there, they knew the name of the organization, but they felt comfortable bringing the complexity of life during the pandemic, and surfacing that as part of the conversation. So our approach has always been to be very tangible with what we can deliver, whether it's masks or tests or vaccines, but also using that as a portal for understanding all of the various ways in which suffering has been experienced during the pandemic, so that we can take those lessons and build them into longer lasting structural change as well.
Thank you. And just sticking with that, look, that's how we build trust in the community. But how can we ensure that we're providing appropriately sensitive material and messaging to the communities that we're looking to serve?
Yes, thank you for clarifying that. We have to have the feedback loop at the end of the day. And that means that the health department, has to listen to the feedback that we're getting, both from the organizations themselves and more importantly, from the people whom we're serving. I'll just give you another very concrete example. I visited our Tremont Health Action Center in the Bronx during the peak of the Omicron surge. We were handing out rapid test kits, to the surrounding community there. It included a NYCHA development that was just a walking distance away from that action center. And we found that in many cases, people were taking the test kits, but they didn't quite have the health literacy or even the English proficiency to be able to know how to use the test kit appropriately. As a result of that, we've set up videos in different languages. We set them up at the same place where we were actually handing out the test kits and said, please, take a photo of this or, take this link to the video itself so that you know how to use the test kit so that it's actually useful to you, at the time when you may have to, use it for yourself or a family member. And because of that, we changed some of the signage and the ways in which we were describing the test kits at the time they were being handed out. So that's just a small example, but I hope it conveys our approach with respect to iterating on the feedback that we're getting from community members so that we can share that information in a way that it's actually most relevant to the people that we're serving.
Thank you. I have two more questions, then I'm going to turn it over to my colleagues, and if anything, I'll come back. But I just want to ask these last two questions. It deals with the contracts. Can the department provide a list of the RFPs and other funding opportunities that are available for CBOs to provide support for COVID-19, through the department? And can the list of awardees for each RFP actually be provided to us as well?
Thank you, Chair. And the answer to both is yes. We'll be happy to follow up after the hearing with a list. All of the current open RFPs are public. They're online on the Fund for Public Health's website. The Fund for Public Health is our nonprofit partner, but we'll be happy to generate that list and send it to your office and the council as well.
Would you happen to know what the total amount of funding available is?
It's about $125 million that's gone to approximately 100 community-based organizations and 17 federally qualified health centers thus far.
Okay. And how do the different contract opportunities differ within the department and differ from the opportunities within H&H?
Well, first, let me just start by saying that we've had such a productive relationship with health and hospitals over the pandemic. Public health and healthcare delivery have to work hand in hand in order to actually improve health, which is our common goal. The way that I think about it is one of my patients at Bellevue or one of our neighbors, Chair Moya, in Jackson Heights, doesn't care so much about the distinction between health and hospitals and the health department. All they care about is trying to stay healthy and access care when they need it. And so this means we try to take the various contract opportunities and sort it out on the back end so that what we're presenting is a united front for New Yorkers and for the city as a whole. So I'll just give you one example. The health department's arm of the Public Health Corps that I've mentioned focuses on community level education to prevent COVID, while health and hospitals, although they also use community health workers, focus on providing support to those who are already within the healthcare system for complex problems. So in this way, it's complementary. You know, us, public health, doing what we do best out in neighborhoods, you know, working in communities, making real that place-based approach that I've described, and health and hospital is really focusing on excellent clinical care and healthcare delivery.
Great. Thank you, Doctor, for answering my questions. Really appreciate it. Thank you for that. I'm going to now turn it over to our council, because I know we have council members that are eagerly waiting to ask some questions. Thank you.
Thank you.
Thank you, chairs. I'm now going to call on council members in the order in which they've raised their hand on Zoom. As a reminder for council members, if you'd like to ask a question and you've not yet raised your hand using the Zoom raise hand function, please do so now. Council members, please keep your questions to 5 minutes. The sergeant at arms will keep a timer and we'll let you know when your time is up. You can begin as soon as I've called on you and the sergeant has announced that you may begin. We'll start with Councilmember Barrett, followed by Councilmember Brooks Powers, followed by Councilmember Narcisse, Councilmember Mealy, and Councilmember Brewer. Councilmember Barrett, you may begin when you are ready.
Well, thank you very
Starting time.
much. Thank you very much. My problem with your presentation and with your commercials, you do not address the deeply rooted, systemic, structural, racist problem in the healthcare delivery system and the capitalist greed by the pharmaceuticals. All of this talk is easy, even though it's a pandemic, because you can talk about the stuff you've given out and the stuff you're doing and addressing racism, community engagement, $25 million, which is pittance, provider engagement, access to resources, data. We didn't need no data to know who was dying in the Black and brown communities. I didn't hear from you when the governor, when we were dying, decided to change the Javits Center into a health facility, sent that ship with 1,000 beds to the white community, converted Central Park in the white community. They were dying least. When all of that was happening, heard nothing from you and nothing from others. When the governor had the unmitigated gall to write a book on the pandemic after he cut Medicaid by 2.5, excuse me, by $2.5 billion. I didn't hear from you. And cut Medicaid, and you know what he called it? The Medicaid redesign program. Oh, I'm not cutting stuff, Charles. I'm creating Medicaid savings. I hear nothing from you on that. I hear nothing from you on the high cost of prescription drugs for our seniors that now have to suffer. And some of our seniors can't take the vaccine because they have so many allergies that it'll be very, very difficult and risky for them to do that. And some of the doctors recommended that they just stay away from it and keep them out of an unsafe environment. Didn't hear nothing from you over the years. I've been in this struggle for 50 years, even way back when Haskell Ward and Mayor Koch, remember planned shrinkage, closing hospitals in our communities, whether it was Sydenham, Cumberland, planned shrinkage. Heard nothing from y'all. How about this? How about the fact that they're merging hospitals now? Merging hospitals. You know what a hospital merger does? You should know. A lot of the services go with the merging of hospitals. Heard nothing from you. It's easy to come with this, as you say, eloquent presentation by the mayor and you around a pandemic, giving out masks and having sites. We've all done that. All of us done that. We've given out masks. We've had sites in our neighborhoods and all of that. We fought for all of that. Didn't hear nothing from you on the systemic problem, the real problems, Medicaid cuts, hospital mergers. And you know who the primary caretaker is in our communities? The emergency room. And most of our hospitals survive on Medicaid reimbursements. 80% of the hospital's income is on Medicaid reimbursements, and they're cutting that and making that difficult. Even in the Obamacare, the private companies laugh their way to the bank because it's still very public. I didn't hear you supporting single-payer healthcare system that would provide healthcare free for everybody and paying some of their taxes out of it. So I'm getting sick and tired of these flowery presentations, putting together a coalition, a commission on racism and this and that. You know how many commissions and task force we've had? You don't need all of that. There's nearly $100 billion budget. And you're talking to us about $100 million and $25 million here and engaging the community. That is peripheral. That is not systemic. It's not deep enough. We need you, or I need you, if nobody else does, go deeper, because we were dying before this pandemic from high blood pressure, diabetes, lung diseases, kidney, heart. All of that was happening because of racism and capitalist greed. Want to talk about a pre-existing condition? We're suffering because of a pre-existing economic exploitation condition of our community that creates poverty. And what's in the vaccine? I think people need to know the ingredients of it.
Time expired.
Thank you, council member. Look, I hear the passion in your voice and also the frustration, and I have nothing but deep respect for the work that you've been doing across decades. So I'm grateful, for that, and I also share, your sense of urgency and your sense that things need to change in a much more significant way rather than an incremental way. It is why I and the health department have been calling for massive investment in public health, massive investment in the safety net systems, that you've alluded to, and doing it in a way so that we don't rely on emergency rooms or hospitals as much, but actually try to address all of those factors through primary care, but also all of the things that we know contribute to health that don't have to do with healthcare. So you'll find me in violent agreement with, with much of what you've said. And I and the health department look forward to partnering with you to actually drive that structural change.
Thank you, Councilmember Barron. I'm going to now turn it to Councilmember Brooks Powers for questions. You may begin when you are ready.
Starting time.
Thank you. And hello, everyone. Thank you to Chair Schulman and Moya for convening this important hearing today. The COVID-19 pandemic has exposed deep inequities across our city. And I think it's really important for us to keep in mind that different communities have felt the impacts of this pandemic very differently. Communities of color, like the one I represent in the 31st Council District, were hit first and hardest by COVID. We have struggled to recover amid a healthcare desert and uneven allocation and distribution of resources, and difficulty in addressing both misinformation and genuine concerns surrounding the safety of vaccines. In many of my district's zip codes, about 1.7 of people are testing positive, which is fairly close to the current citywide average. However, only about 63% of my district residents are fully vaccinated, compared to a citywide rate of 76.6%. That rate is as low as 54% in 11691 downtown Far Rockaway, the second least vaccinated zip code in the city. In light of this reality, I want to focus on how the Department of Health and Mental Hygiene and other city agencies are centering equity in their work with communities across the city. A couple of questions that I have include, as some communities across the city reach herd immunity levels of vaccination, how are the agencies redistributing resources to help other communities most in need? Can the city provide a breakdown of how many vaccination sites Permanent, brick and mortar, and pop-up are in operation. Does the city plan to close any existing sites or open new ones in the coming weeks? DOHMH's Equity Action Plan seeks to ensure that our COVID response is equitable, using quote unquote population-specific strategies to better reach community members. How has outreach looked in immigrant communities or communities of color where vaccine hesitancy may be higher? Have outreach strategies changed as the vaccine uptake increased? Over the past couple of months, many New Yorkers increasingly began relying on at-home test kits provided by resources like the federal government. And because these kits aren't administered and collected by a central office, we may be missing some crucial data in terms of which neighborhoods are still being hit hardest. Have your departments noticed changes in testing data that might be the result of this gap? Have you found that at-home test kits are used disproportionately in certain neighborhoods? And if so, has that prompted the agencies to redistribute resources, redirect their focus, or change the strategies? I know that's a lot, so feel free to let me know if you need to any questions, but like I said, this is a much needed conversation, especially when you have communities of color that continue to be left behind when the resources are distributed.
Thank you so much, Council Member. A number of questions there. Let me do my best to address several of them briefly. But first, the most important one is where you ended up, which is we can elaborate our equity strategy, but what really matters is what you're seeing, in your communities and whether we're closing the gaps that we aim to close. And I will tell you that, certainly part of the district that you represent has been one of the more challenging places in terms of closing the vaccination gap, for 11691, as you alluded to. I'm very grateful for the partnership that we have had with you and your office to ensure that there is sufficient access, both mobile sites as well as working with the healthcare providers who are in that community as well, and also trying to stem the misinformation, that we know can also contribute to lower vaccination rates. So that remains, a very active concern of ours. We monitor vaccination rates by zip code, and if necessary, at even more granular levels on a weekly basis to understand where we need to continue our focus, redouble it in certain cases, and bring to bear, additional interventions to raise those vaccination rates. With respect to your question about showing or sharing the locations of the current vaccination sites, both mobile and brick and mortar, yes, of course, we'll be happy to do that. Much of that is on nyc.gov/vaccine finder, but if there's any more specific cut of that, we will, of course, be happy to share that with you. And then the final piece is about test kits. I alluded to this a little bit earlier, but to recap, we are monitoring to ensure that we're getting sufficient surveillance testing, both citywide as well as at more granular levels. If that changes, then certainly, we would reconsider any of our testing strategies, making sure that there's sufficient access to testing in specific places, and thinking about how we may need to integrate home test kit results into our strategy as well. Thus far, we have sufficient surveillance across the entire city, as well as in the zip codes that we monitor across all 5 boroughs. So we do have a good sense of the trajectory of the pandemic in real time from our existing testing approaches, but that's something that we monitor week to week, if not day to day. I hope that answers some of your questions.
Thank you. I'm going to now turn to Councilmember Narcisse. for questions. You may begin when you are
Good
ready.
morning, Council. I just wanted to just close out by saying thank you, Dr. Chosky, for your partnership as well, because yes, we have been working extremely close. I will like to end on one note in terms of the distribution of I know you guys are partnering with the public libraries, but there are still communities that are not receiving them. So when you look at my district, Laurelton, Roseville, Springfield Gardens also have low numbers, and none of the public libraries have been selected as a part of this effort. And I would like for the agency to consider adding the Rosedale as well as the Laurelton Library as well.
Thank you, Council Member. We'll be happy to follow up with you about that with our T2 colleagues as well. Thank you.
Thank you, Councilmember. I'm going to now turn to Councilmember Narcisse for questions. You may begin when you are ready.
Starting time.
Hi, good morning, and thank you, Chair Lynn Shulman, my colleagues, City Council, and Chair Moya. Thank you so much for the opportunity, and thank you for taking that on. And thank you, Dr. Dave Shavusky, I think. Yeah, I hope I don't butcher your name because thank you so much. One of the things I have to say, I have been a nurse for over 30 years, work emergency room, Elmhurst Hospital, by the way, work home care. We never faced that before that pandemic. But having said that, this pandemic just exacerbated what's been going on in our community. And everyone piggyback from Council Member Barron. Everybody knew the inequities that existed in our community. And from all the diseases that he mentioned, diabetes, hypertension, and so on and so forth. But when the pandemic hit, the first delivery of things was not received by our community, which everyone knows that when you have underlying, and those are the folks that need the attention the most. So we did not have that. When it comes to the testing, when it comes to the protection, all the PPEs, they were not distributed in the community that needed the most. So this got to stop. We have to do better. We cannot go backward. We have to go forward. We have to help people that really in need the most, because we already knew that. I have two little questions. I'm not going to take long. I know a lot of things been covered, and I thank you all for the opportunity and talking and trying to touch all the bases. What is the racial breakdown of vaccination rates across each borough by zip code to compare with breakdown for infection, hospital, and death rates? That's one. With infection rate decreasing, we all know it's decreasing, and I would not like to see everybody put their guard down. I believe it is very important to not jump the gun, right? And tear off all our masks and claim that this pandemic is behind us. How is the city preparing to distribute information and provide clear directives to all New Yorkers, especially in the community that need it the most, which is a high-risk neighborhood, about proper and effective protocols for wearing masks and being vaccinated over the summer months? I'm gonna leave it as that. Thank you.
Well, thank you so much, Council Member. I'll start and I'll see if Dr. Vasan would like to address particularly the last part of your question as well. But first, allow me to just echo what you've stated with respect to how important it is for us to realize that the pandemic simply magnified inequities that existed before COVID-19. Unfortunately, in many tragic ways, but also in ways that we have to recognize reflects generations of disinvestment and discrimination, and in so many cases, structural racism that contributed to those tragic outcomes that we have borne witness to over the past 2 years. But we cannot simply look backwards at that. We have to take the steps, as you have said, to redress those inequities, and particularly with the notion that health equity is fundamentally about ensuring that we allocate the resources that generate health according to need. And that is at the center of how we are thinking about, this next phase of the pandemic. Some of the ways, of course, are more directly related to COVID response. So to your question, are vaccination rates by borough, actually broken down by zip code, as well as age range, are at nyc.gov/COVID data. What they show is that Black New Yorkers remain the lowest vaccinated race ethnicity group at 57%, followed by white New Yorkers at 61%, and then followed by Hispanic Latino New Yorkers at 70% fully vaccinated. But as you've alluded to in your question, that varies widely depending on geography as well, and in many cases, depending upon age too. So we have that more granular data broken down on our website, as I mentioned. We have to match that up, as you pointed out, against what we saw with cases, hospitalizations, and deaths. And, the upshot is that populations that have lower vaccination rates unequivocally are at higher risk of infection, as well as the severe outcomes from COVID-19. Even though we did make very significant strides in protecting so much of New York City with our relatively high vaccination rates overall, we have to pay attention to places that have lower vaccination rates, whether it's specific race ethnicity groups or neighborhoods, in order to ensure that they benefit from that same level of protection. And that gets to the last part of your question, which is the how of, how we're attempting to do this. A lot of it is through the community engagement and clinical engagement, that I've already described. But I just want to underline how important it is for us to rebuild the fundamental public health infrastructure that we need. We have to invest in it in the same way that we think about roads and bridges, for us to not be in the same situation that we were in when the pandemic first hit. This is our opportunity and our moment to be able to do that. And I'll be very grateful for the continued partnership of the council for us to do that, because I know that it will save lives going forward. With that, I do want to turn it to Dr. Vasan to give his sense of the path ahead as well.
Thanks, Dr. Choksi. And I'm incredibly grateful for your question, council member, and for the comments of council member Barron. And I see too the frustration. I share that frustration. I was the leader of a community-based organization that also, was struggling to interface at times and to understand how to respond to this pandemic in partnership with government. And so I understand how that the effects of that fall disproportionately on people of color and people who already have vulnerabilities, like the folks I used to work with chronic mental illness. I will just say that one of the things I'm most excited about is the progress that the health department has made over years in our work on place-based, race equity-based strategies. I was privileged to be at the health department for a short time when Dr. Bassett really created the space for a conversation about racism and health that, at least in government, didn't really exist. New York City government didn't really exist. And I saw her, through her force of leadership and will, really force a conversation with the agent, internal to the agency, and then also with partners across the government on how can we do better to address the short and the long-term health needs of people most impacted, low-income people, people of color. And I saw the immense amount of awareness and education that was needed at that time to even get us to a shared language and a shared understanding. And then now to come back into the agency and to see some of the early results of that work, obviously under great duress and great strain of the pandemic, but to see, as Dr. Choksi alluded to, the fact that the majority of our first dose vaccinations have been amongst people of color in the most impacted zip codes in our city since August.
I think it's a direct result in part of the beginnings of a way of working more structurally with community-based organizations in those communities most impacted. And so I know it's not enough yet, and it's a start, but when I compare where we were 8 years ago, when we were just having a conversation and raising awareness, to where we've been over the last year or two, I understand that the data still bears out that people of color bore the brunt of this pandemic. But from a government perspective, from a health department perspective, I think this is a stake in the ground in terms of bringing that to life and operationalizing our equity strategy through the organizations that can truly deliver on that, which are trusted community-based organizations that have long-term relationships with people most impacted, can deliver culturally and linguistically competent care. And so as we step back and kind of learn the lessons from this pandemic, one of the main lessons that I see coming in and learning about the response that city government has mustered is our ability to interface with community-based organizations in a much more systematic way than I've ever seen before from the health department side. So I'm encouraged, but there's so much more work to do.
Thank you. I'm just gonna unmute Councilmember Nancy.
I want to thank you and appreciate that, but I have to let you with this. My community, I serve a large population that hit so hard. Canarsie, Sheepshead Bay area. We were on the map, on the red zone for many, many weeks, but yet this district don't even have a hospital, no community health center. And still yet, I'm very concerned as we saying that people getting better, we know we still high risk. So I would like to see, like I think Council Member Brooke Power said, we need to see more PPEs around, especially in our libraries. We're talking about by Seaview Library, Jamaica Library, that can be useful, Rockaway Parkway. Those are the folks that really need help, and Sheepshead Bay area. So we can continue, because I continue doing it myself as a city council, as well as being a nurse. I do a lot of events trying to promote it, but I would like to see more vaccination continue and the site for the PPEs continue. Thank you so much. I appreciate your time.
Thank you.
Thank you, Councilmember. I'm going to now turn it to Councilmember Brewer for questions. You may begin when you are ready.
Starting time.
All right. Thank you very, Thank you very much, Commissioner. And I want to also say during the pandemic, your staff was phenomenal. I was obviously very involved with the community as the borough president of Manhattan, and your staff was phenomenal. Thousands of hours with them, and I can't say enough positive. And also thank you to the co-chairs. So I just want to pick up on what you've been talking about lessons learned for the future, because it seems to me that people did get vaccinated, largely, lots of challenges, but what did we learn from it? Like, do we need more health centers? I know we need to invest, but when I hear that, I want to know where, when, who's making sure that it is planned out. And just as an example, I assume that we're going to have a fourth booster. I don't know. You know better than I. So then the question is, when I get tested, nobody ever says, do you have a health provider? Do you need, help, etc. So and then when I am in Harlem, the Black physicians, I say to them, so what did we learn from pandemic? Answer, more telemedicine is going to be taking place, Gail. So then, of course, I wonder, who's got the connectivity to be able to do that? And how do we operate in a non-siloed situation? So that's question number one, is that it's good to say we need more investment. Where specifically, how, when, et cetera. And your Tremont example is a good one. It's not unique, I can promise you. Number two, all around Manhattan are these testing sites, little tents, freezing cold, and a table. Are they getting, what kind of money are they getting? Is it just reimbursement? Because if there's any city money going into it, I don't know if we need them all. They're all looking for money. That's my impression. I don't know. And then there's the issue of home testing. I heard you say correctly, you have enough data, but just so you know, the pharmacies that I talk to, it's a much higher rate of positivity than what you're hearing on the street in terms of the data, because people are coming in, they're getting tested, but then they call the farm, we're all positive. That's okay, as long as it's good that you know that. But I just want to let you know, I think the home testing is terrific, but there's much higher rate of positivity than what you're getting from your data. And then just in terms of the hotels, I just didn't know if there's still COVID hotels. The reason I ask is it would make some sense if we could piggyback with the homeless, because these homeless folks are not going to the shelter. So couldn't we find a way of also, can you get reimbursed? I'm trying to think of other ways to not have silo agencies. That's my goal in life. So those are my questions, and thank you so much for everything you've done.
Well, thank you very much, Council Member. You've been a terrific partner of ours, first as Borough President, and we're looking forward to working with you as a Council Member again. And first, let me just say thank you for shouting out the Health Department staff. I really, I can't say enough about what heroes, my colleagues have been, the endless hours, that they have dedicated to try to keep New York City safe. And I'm continually in awe and inspired by them. So I appreciate your acknowledgement of that. Let me try to give brief responses to your four questions. So thanks for asking the really thoughtful question about investment where. And I will say, sort of three areas that are top of mind for me. First is community health workers, and making sure that we are looking at this as a chance to do a quantum leap when it comes to our health workforce, and actually, do it in a way that invests in communities rather than drawing resources from communities. And that's what community health workers represent at the end of the day. The second part of it, Dr. Vasan has already alluded to the fact that both he and I are primary care doctors. We chose that because it's the natural place for people who care about public health to take care of people. We have to invest much more into primary care, including our federally qualified health centers, but more broadly, making sure that that the places, particularly in the boroughs, of Bronx, Queens, Staten Island, and Brooklyn, that don't have sufficient primary care access right now, that is rectified as well by improving access to primary care. And then the third part is for us to recognize all of the other drivers of health, which we've spent a little bit of time talking about, but food, housing, education, all of these things that end up shaping health outcomes, in many cases far more than healthcare does. And those are places where Mayor Adams has already demonstrated and signaled a very strong commitment. And I'm really excited to see the different ways that we'll be able to partner with the council and under Dr. Vasan's leadership, actually address those drivers of health. Sorry, council member, to take up your time. I'll just take a couple more seconds to talk about the testing sites that you mentioned. Those are not under the direct purview of the city. Most of them are regulated by the state. We encourage for people who are seeking testing to go to health and hospitals or test and trace core sites.
But I know that, Commissioner, but do those companies get reimbursement that is not city? There's no city money in that. That's what I'm trying, or maybe you don't know.
To my knowledge, there's no city money in those. They may get insurance reimbursement, and that would be state money, via Medicaid and other plans. But we can confirm, council member, but to my knowledge, no city money. The third one on home test kits. Yes, I do understand the point there. We will, continue to look at our indicators. It's not just about cases and test positivity. It's also about all of the different ways that we have to understand the trajectory of the pandemic. We get real-time information through what's called syndromic surveillance to understand what's happening in our emergency departments and hospitals. And so if any of those signals go off, we know, to be able to dig deeper. And we're now, quite seasoned in being able to do that, having experienced it in 4 consecutive waves. So it's something that we'll continue to monitor closely. And then your point about hotels is well taken. We may have to owe you a bit of follow-up here, but I do know that health and hospitals and, for example, the Department of Homeless Services have a very good collaboration when it comes to isolation hotels that have had to be used for different purposes during the pandemic. And I hear your point, which is more about doing this in a forward-looking way for the capacity that we may have to maintain.
Okay, I appreciate it. I wanted to say one thing. It's still silent, because if we get tested, then where is the follow-up for the person who's only getting the shot? Do you have a primary care provider? Do you belong to a health center? I've never been asked. I get tested all the time. I love going to see how it works. I just stop in all over the place. Nobody says that. I don't know if it's a good idea or bad idea. You can have all the healthcare workers you want, but when you got that person there, he ain't coming back. So that's the silo problem. Because otherwise you're going to have the same Tremont situation with people upstairs not knowing what's going on downstairs. So I'm trying to get the silos. If we have this booster or the 4th shot, that would be the time to say, okay, let's work on that, because we have sort of more or less, figured out the other challenges. But how do we make sure that people have a primary care or whatever is the right way in terms of public health? I'm all for the Ryan Center. That's my thing. But that doesn't happen right now.
Thank you for the comment, Council Member. And I'm sure there are ways for us to continue to improve along the lines that you're saying. For positive test results, there's proactive follow-up if it's reported via laboratory. For home test kits, we're encouraging New Yorkers to call 212 COVID-19 to make sure that they get connected to the resources that they need, and particularly making a push, and would really like to invite everyone's help with this, to make sure that people know that treatment is available. It is highly effective treatment, and it works best, if you start it sooner after testing.
I just want to say, even if you're negative, if you have nothing wrong with you, I'm talking about other kinds of health needs.
Yes.
I just want to jump in here really quick, Councilmember Brewer.
Sorry.
No, it's okay. We have 5 minutes for everyone, and you can come back for a second round for 2 minutes.
Okay.
We just want to make sure that all of our colleagues get an opportunity to
thank you very much.
Yep, thank you.
Thank you, Councilmember. I'm now going to turn to Councilmember Mealy for questions. Before I do that, just quickly, a reminder for any other council members, if you have questions, you can use the Zoom raise hand function, and we'll call on you in the order in which you've raised your hands. Councilmember Mealy.
Hi.
Starting time.
Thank you, Chair Shulman and Moya. Thank you for this important meeting. Thank you, Commissioner. I haven't really met you as of yet, and my district is the most needed district than ever. And I keep hearing quality, trust. And I haven't heard that much. What is your plan in regards to the most vulnerable population? And that's our seniors. And you said you had your community health workers knock on 1.7 million doors. But do you know the stigma of people knocking on senior doors? I want to know how many home COVID tests you were able to get in to their doors. So many scams are going on right now. And I feel our seniors probably thought, here go another one, taking their information. And another question I have, you said you had so many PSAs, but I didn't see any that was geared directly towards seniors. And our African-American and Latino, sometimes you need to go old school, I can say, to get them to really feel that you're with the city and I can open the door and trust you and let you vaccinate me and then leave. And I may open up the door again when you come. So I didn't see any PSAs in regards to that. And in my district, that is the highest population of, oh God, you wouldn't believe, highest density of public housing. And the vans I go see and talk to, I don't know if they from the city, or if it's just people popped up and have their own private van doing these tests. Numerous people are coming into the office now are saying that they still have not received their results. So who are regulating all these pop-up tests and these vans? How would the community know if this is a city van or if this is a private entity doing these tests? And they really gonna get back to me and let me know if I'm positive or not. And then I'll be quick. The home test, after I'm doing food distribution, PPEs, the test, home test. After I give them the test, then what? How do we know if it's positive or not? How are we following up with the individuals who receive these tests at home? So I would love to, sooner or later, we're gonna meet and start communicating and seeing how we can best serve the community, but we have to do a follow-up on these tests. What is your plan with that? And our PSAs for our seniors. Thank you, chairs.
Well, thank you so much, council member. First of all, I look forward to meeting with you, and I really appreciate your comments, and you're shining a spotlight on older New Yorkers and our obligation to serve them well. This is something that has weighed very heavily on me because we've seen how much COVID affects our seniors more so than even other New Yorkers. So thank you for calling attention to it. Let me try to briefly address you had 4 related questions. I'll try to briefly address them. With respect to how we are engaging seniors and really trying to do it in a way that forges trust, because as you said, it may be a high barrier for someone to open up a door, if someone's knocking from one of our canvassers. We do recognize that, we've had multiple vaccine planning work groups that coordinate the different parts of city government, particularly the Department for the Aging, as well as the Health Department, but also bringing together advocates and nonprofits who specialize in supporting the needs of seniors. And this is another area where our job is sometimes to just make sure we empower and give people the resources and get out of the way. So whether it's making sure that senior centers or home delivered meal programs or the home care and care management programs that I've alluded to have what they need to take care of seniors. That's a major additional way that we're trying to engage that community. We, for our part, have launched free transportation options to vaccine sites. And beyond the door knocking, we do thousands of daily calls between the Test and Trace Corps and the Department for the Aging to help people make appointments or to set up, the in-home vaccination program that I've
Time expired.
Before. So that's a little bit on seniors and trust. The second part of it, in terms of the PSAs, we have had PSAs that are specifically targeted to seniors. Commissioner Cortez Vasquez and I did one last year, and then the Department for the Aging, in collaboration with the Health Department, put one out around the time of the Omicron surge, and you'll see more about that in the coming weeks as well. But this is an area where we welcome your thoughts and particularly the right way to deliver the message so that it's received by the people whom we aim to reach. In terms of the pop-up testing sites, those are generally, as a testing entity, they're regulated by the state. But if there are specific, problems that you're seeing, certainly you can report them to the Health Department as well, and we'll figure out the right way to channel that feedback or guide you, in terms of the right way to do so. I do understand the concern that you have raised and that Councilmember Brewer, also raised, to make sure that they're not taking advantage of New Yorkers and particularly older New Yorkers. So I do understand that. And what I ask is that you help us to get the word out about directing New Yorkers to the city sites that are listed at nyc.gov/COVID test, or anyone can call 212-COVID-19 if they don't have internet access. And then in terms of follow-up related to home tests, thank you. Another very important point. We do, as we're distributing the home tests, we make sure that people have the material to know whom to call, either their own healthcare provider if they're established in care somewhere, or 212 COVID-19, where they can speak to one of my nurses or a health and hospitals doctor if that's necessary. And we mostly want to make sure that people know how to access that follow-up as rapidly as possible. So thank you again for raising those issues. I hope I've addressed some of them, and we'll look forward to following up on anything else that we need to.
Thank you, Councilmember and Commissioner. And that I don't see any additional Councilmember hands at this time, so I'm going to turn it back to Chair Shulman for additional questions.
Thank you very much. And, I want to thank Commissioner Chokshi and Dr. Vasan for being here so long. I want to mention, and my colleagues as well, I want to mention that we haven't had a COVID hearing, the council hasn't, in at least a year, if not more. So that's why this is so important, and that's why this is so substantial and significant. And we appreciate you taking the time to really stay with us today and work through this. This will be one of many, but we appreciate it very much. I'm going to return back a little bit to vaccine hesitancy, which my colleague Chair Moya alluded to, and some others as well. One is, what are the most common concerns raised by those who are hesitant to receive the COVID-19 vaccine? And how is DOHMH targeting communities that still lag in vaccination rates?
Thank you so much. I'll start. I'll see if Dr. Vasan would like to chime in on this one as well. He's also been thinking about, sort of more the newer and some creative ways that we can continue to address this issue, which we always think of as building vaccine confidence. Our starting point is and should be that we have these extraordinarily safe and effective COVID-19 vaccines. They've saved tens of thousands of lives just in New York City and averted even more hospitalizations. And so our job is to communicate that accurately, scientifically, but in a way that recognizes that people interpret vaccines and vaccination in different ways, depending on their backgrounds, their prior experiences with the healthcare system, and a range of other factors. So as I mentioned earlier, we do, very actively monitor and have surveillance on different attitudes around vaccination. We do this through surveys that the health department fields every few months to understand attitudes toward vaccination. We also have a very sophisticated apparatus, I believe the most sophisticated way of tracking misinformation of any local health department in the country. We monitor social media. We work with our community partners to understand, what is circulating, and then we ensure that that is used to tailor our own messaging. What we're hearing is, similar to the threads that we've heard in prior months, some concerns about safety of the vaccines. People, particularly during Omicron, when we saw that there were higher infection rates because it was so transmissible, including a number of people who were vaccinated who got infected, and people thinking that the vaccines are not effective because of that, as well as some continued concerns around fertility and other side effects related to vaccination. So those are things that we're well aware of, that we do some targeted messaging around. We call out when there are specific elements of misinformation on technology platforms to help to make sure that those are taken down. But then most importantly, it's about working through our trusted messengers. These are our community-based organizations and the faith leaders, that you've heard me talk about before, working with them so that they are armed with the information that they need to combat that misinformation, and to do it in a way that really reflects that these are iterative conversations. I think about my own patients whom I've had conversations about vaccination with, And sometimes it's not the first conversation or even the second or third, but the fourth or the fifth or the sixth, where they start to get more comfortable with the idea. And so we've invested a lot in making sure that clinicians have the information and the resources that they need to have those repeated conversations, but also brought that same philosophy to the other trusted messengers so that they can have conversations over time with people who may have some skepticism regarding vaccines. So let me conclude my comments there, but I'd like to invite Dr. Vasan to chime in as well.
Yeah, thank you for the question, Chair. This is a really challenging environment in which to do public health messaging and communication, and I have a great deal of empathy for all involved in that kind of messaging, especially we're dealing with the after effects of an administration, a federal administration that was questioning the very basics of whether this was a real thing or not, whether it was a real pandemic. Imagine as scientifically trained practitioners, servants of others, to have to go up against that sort of misinformation, disinformation apparatus, which exists, which continues today. It's a very, very formidable opponent. And so I really tip my hat to the health department, to Dr. Choksi and the team for their efforts in the face of that incredibly formidable opponent and calling them out publicly. And we appreciate the council's support of that, because it is going to require you all as legislators and at every level of government to start to regulate the flow of this disinformation and misinformation that we're up against. And so I would say that that's kind of the defensive position that communication in public health has been in since the beginning. But as we talk about the more proactive strategies to overcome this, I think about two things. One is, as Dr. Choksi said, really, people want to hear from the people they trust. Often those people that they trust live and work and serve directly the communities that that are most impacted. I know this not so much in a place-based way, but we ran a vaccination clinic at Fountain House, my previous employer, and you can imagine how much mistrust there is amongst people with mental illness. You have not only the fact that these are vulnerable communities, mostly of color, but the fact that they've got the interfering symptoms at times of their chronic mental health conditions. It was a real challenge to get our population vaccinated. We got over 90% of our members, 5,000 members across the city, 90% of them vaccinated, in large measure because we engaged them directly, we answered their questions, and the questions were answered by credible, trusted people. Yes, they wanted me in the room to build confidence, but the message that landed the most was when that was delivered by their social worker, their peer, their friend, their member of the Fountain House community. And so that was a huge lesson, an object lesson in building trust for one of the most socially isolated and vulnerable groups in our city. And so as we think about going this last mile, reaching the people who remain unvaccinated or under-vaccinated, I know that there's a commitment at the health department to continue that sort of engagement. And I'm committed to thinking about creative ways to increase those sorts of messages, because I understand that we have a role as the government to provide citywide messages and guidance to everyone, but there may be specific communities that want to hear messages in a specific way. I think the other piece here is a time to revisit is behavioral science. We've talked about this in sort of the public domain, but what do we know about how people make decisions beyond what we think about trust? There are other triggers, incentives and signals and using locations and other ways of marketing vaccinations and other interventions that I know that this mayor raised on day one of his administration is, what are we doing to reach that last mile? And I think this is also now going to be particularly important as we consider under 5 vaccinations and rolling those out. as well as increasing our rates of vaccinations amongst 5 to 11-year-olds. I'm a father of 3. They're all below 8. My youngest is 2.5. I want him vaccinated as soon as it's possible. I got my older kids vaccinated as soon as I could, but I know what slice of society I live in, and that I was already predisposed to do that for a host of reasons. So how do we reach those other slices of society that may have other economic, social challenges to actually getting vaccinated, or combating cultural misinformation, disinformation, messages delivered in ways that aren't landing? This is a really important effort, especially as we think about mainstreaming these vaccines going forward for our children.
Well, no, I really appreciate you bringing that up, Dr. Vossen. And in fact, I was going to say there's particular mistrust because of political partisanship, which is what you were alluding to, earlier. And that's in my community, that's very significant in my district. So that's something that, yes, we're going to have to really work very hard toward. And I don't think there's any one particular answer. I want to follow up Councilmember Mealy's questions about older adults. Currently, 68% of those 85 and older have received 1 dose of a vaccine, despite being one of the most vulnerable populations. Comparatively, those 75 to 84 years old have an 84% vaccination rate, the second lowest vaccination rate of adults in the city. And those aged 65 to 74 have a 95% vaccination rate. How are we addressing the low vaccination rates for those 85 years and older?
Yes, thank you so much, Chair, for pointing this out, and particularly that disaggregated data, which we've also been following, with some concern, given that the risk of severe outcomes, as you well know, increases with age. And so, any additional senior that we're able to get vaccinated, and particularly those older than 75 or older than 85, it really matters with respect to their protection. So this has been a major focus of ours. I outlined a handful of the approaches that we've taken thus far, but I would say particularly for the oldest New Yorkers, ensuring that we have done everything possible to reach them through the other avenues that we know that they're getting care, whether it's a meal delivery service, whether it's home care, whether it is a geriatrician who is taking care of their needs as an older adult, their healthcare needs, and partnering with all of those groups to make sure that they're aware of how to bring vaccination as conveniently as possible, for people who are in that age group. The in-home vaccination program, New York City was one of the first places, I'm proud to say, that opened it up to, broadly to anyone who's eligible, but we've particularly focused on making seniors and family members of seniors aware of that option, including for booster doses. So this is an area where I do hope that we will continue to make progress, both for initial vaccinations as well as for booster doses, and certainly an area where we welcome collaboration and any ideas from you and the other council members.
Yeah, and I also want to point out that I know you're working with the Department for the Aging, but particularly during the height of the pandemic, I got complaints from people in my district about the fact if they did not belong to a senior center, they kind of got lost in all of this. So I want to see what you are doing to reach out to those seniors that are not part of senior centers.
Yes, thank you very much. And it's only a subset, as you're saying, of older adults who who do cross the threshold of a senior center, as it were. And so we have a number of other avenues that we use to be able to reach them. Direct mail. We know that direct mail is usually more likely to reach older adults than, for example, robocalls or some of our other, more internet-based approaches. We have obtained lists of older adults in New York City from, for example, Medicare or other partners who already serve older adults. The AARP is another example, and we actually have our own nurses do calls, based on those lists, and can do what we call a warm handoff to be able to get them connected to an appointment with transportation or to schedule a time for the in-home vaccination option. And then beyond that, we do know that visiting nurse services, other home care agencies, they already take care of, many people who fall in this age group. And so we've been working with them either to supply them with vaccines themselves or to make sure they're aware of the in-home vaccination program and our other ways of facilitating access to vaccination. The other thing that I'll say specifically related to boosters is that I haven't had a chance yet to mention that we have a $100 incentive that Mayor Adams has reinstituted that will be through February 28th. This is not just for first doses, but also for booster shots as well. And that's another thing that we would love your help in getting the word out to make sure that people are aware, because we know that that $100 can often make a big difference for people who are on fixed income as well.
I also want to offer just a thought of thinking outside of the box. There are lists that are sold to people who run for office, of people who are registered to vote by age and all of that. And maybe that's a place to buy those lists and use those as well. I'm just to just point out, rather than the traditional government lists.
That's a great thought. Thank you, Chair. We may follow up with you on that.
Okay. While we appreciate receiving reports about the at-home vaccination program, the reports do not disaggregate by age. How many seniors have taken advantage of the at-home vaccination program? And what can we do to boost participation in that program?
Thank you very much. And again, we're really heartened by the uptake that we have seen in the program thus far. My team, I'll ask to follow up with a more specific number, but I know it's over 33,000 people that have been served through the in-home vaccination program thus far. This is, we organize it from the city level with multiple different providers. So it is sometimes a bit more difficult to disaggregate that, for example, by age. But of course, we're happy to discuss this further with our interagency colleagues that help us run the program to see what more we can do with respect to that data disaggregation.
So I want to go back for a second to primary and preventive care, because as we all know, regardless of the variant, people will have significantly worse outcomes if they have comorbidities or they have underlying conditions. So I want to know, I would like to see preventive and primary care programs, not just in, we were talking about underserved communities. My community is not so much underserved, but I have one of the highest, if not the highest number of seniors in my district. And so I want to make sure that we have resources, regardless of zip code, wherever you live in the city, that people can have access to primary preventive care. I will tell you that in talking to people in my community, sadly, a lot of them, when I ask them where they get their health care, they talk about urgent care centers, and that's not the place to get health care. I don't have a public hospital or a public health center in my district, but I just wanted to put that out there that you should look at other neighborhoods in addition to the ones you're already looking at.
Thank you so much, Chair. And I really, and not surprisingly to you, I very much agree with you, as a primary care doctor myself. And I've seen this, with my own patients with respect to foregone care over the course of the pandemic, whether it's people missing a mammogram or a colonoscopy, or not refilling their blood pressure medication, or falling behind with respect to their diabetes care. These are very real reverberating effects of COVID-19. They're not directly related to the virus, but they're no less impactful when it comes to the health of New Yorkers. So we are putting a number of efforts into, making sure that people are getting back into that regular routine care. Another area that I have to highlight is childhood immunizations. We know that that parents have fallen behind with respect to getting their kids vaccinated, not just against COVID-19, but against all of the other, routine vaccinations that they are due for. So we have to make services more readily available, but also make sure that people know how to navigate to them. So one example is NYC Care, which is specifically for people who are uninsured. They're able to access healthcare at the health and hospitals system. But beyond that, we do encourage people to call 311 to get connected to care in their neighborhood. We have a network of community health centers that extends beyond health and hospitals that we can help people get linked up to, in your district and more broadly. And the final thing that I want to mention is that, the mind is, the head is connected to the body, as we know. And so, we have to think about routine care when it comes to mental health as well.
Yes.
We have to think about it as not something that is separate or different than physical health. And so one of the things that we've really tried to promote even further during the pandemic and beyond is NYC Well, which is the front door, for anyone who's trying to access mental health services for themselves or for a loved one, which is particularly important given the immense trauma and grief and stress that people have experienced over the past 2 years. So this is another area where you'll see continued focus and part of our initiatives to address the parallel pandemics that I mentioned in my testimony.
And I appreciate that. One of the things I want to work with you on too is to try to get people hooked to primary care, because as you know, there are not a lot of primary care physicians and not necessarily ones that are in the other boroughs. There are more in Manhattan. And my primary care physician several years ago decided to become a concierge because they don't get reimbursed enough. And, so that's a whole issue. And I think there should be a way to do that and also connect somebody that needs mental health care as well. So I think there are stigmas there. I think that there are shortages of resources, and we can talk offline about some of that and how we get to a place where people have access. I just wanted to mention that. And I would now like to turn this over to Chair Moya, my colleague.
Thank you, Chair Schulman, and thank you again, Doctor. Thank you both for being here. We really appreciate you taking the time to meet with our committees and talk about these very important issues that we will follow up on. But I know that we have other people that are eagerly waiting to testify, and I just want to be able to move that forward. So I'm going to thank you. I'm going to now turn it over to our counsel to continue with today's hearing. Thank you so much.
Thank you, chairs, and thank you to the administration for your testimony. We've now concluded administration testimony, and we'll be moving on to public testimony. I'd like to remind everyone that we'll be calling on individuals one by one to testify, and each panelist will be given 2 minutes to speak. For panelists, after I call your name, a member of our staff will unmute you, and there may be a few seconds of delay once you are unmuted, and so we thank you in advance for your patience. Please wait a brief moment for the Sergeant at Arms to announce that you may begin before starting your testimony. Council members who have questions for a particular panelist should use the Zoom raise hand function, and I will call on you after the panel has completed their testimony in the order in which you've raised your hands. I'd like to now welcome our first public panel. In order, I'll be calling on Chris Norwood, followed by Anthony Feliciano, followed by Medha Ghosh, followed by Greg Mihailovich. Chris Norwood, you may begin your testimony when you are ready.
Starting time.
Yeah, I guess I'm ready. Thank you so much. I'm so glad to see these two committees meeting together. It's crucially important. And I'm Chris Norwood, Executive Director of Health People and co-founder of Communities Driving Recovery with Anthony Feliciano, a citywide coalition of community groups looking at these issues from the community point of view, which is often quite different. The New York City is in facing unprecedented mass illness, both from chronic disease and uncountable cases of long COVID. Nothing like this has ever happened before, where chronic disease and infectious disease have collided in a self-feeding explosion. The impact in New York is almost certainly worse than the nation. Witness a 356% increase in New York City diabetes deaths in the first COVID surge. That's 356%. Despite my appreciation for what the city has done for COVID, I really see no evidence, and I don't see evidence here today that they are addressing this intertwined explosion of chronic illness. One of the first steps is to get as many services as possible that make sense out of overburdened clinical and medical centers and get them out into communities. Communities Driving Recovery has presented a plan to fight chronic disease, mental illness, improve nutrition, improve service referral by using the CBOs already in the T2 network. But in addition to that, I really want to address diabetes. This disease has uniquely driven this epidemic, and it is a chief cause of mass illness. The city has never had a plan for it, despite the city council passing a law that requires it to. It has never spent one dime of city money on evidence-based self-care education in communities that slashes complications, it improves mental health, slashes depressions, lowers costs. It won't spend one dime on that.
Time expired.
Thank you. And it hasn't until today. So I'm begging the city council to take up that issue and finally enable people with this disease to have good self-care education in their own communities. Thank you.
Thank you for your testimony. I'll now turn it to Anthony Feliciano. You may begin when you're ready.
Starting time.
Good afternoon. Thank you, Chair Shulman and Moya. I'm Anthony Feliciano. I'm the director of the Commission on the Public Health System. In my 20 years of a lot of this work, organizing and policy, we noticed that we keep making the same mistakes when we come to recovery from a crisis. And I would say that if we continue thinking about not addressing the erasure and the general purposeful lack of understanding of communities' own lived experiences, knowledge, and strengths in taking care of ourselves, we're going to continue making these mistakes. And what I will say is the Department of Health has done much better job, much better. I believe it's because what Chris spoke about a little bit is through the Test and Trace Community Advisory Board and important infrastructure. And I would state that that infrastructure is needed to be expanded and thought through in terms of what we can do as community-based organizations and faith-based organizations. Chris talked about, since we run Community Driving Recovery, about community-based health safety net, using the community-based organization. One of the things is looking at diabetes, but we can present an array of potential projects in the hardest hit communities to effectively implement in 1 or 2 years using the recovery-related funds and finding more sustainable funds. Continuing that T2 community infrastructure, and then outlining a more accelerated type of planning and contracting process. The contracts have not worked as well as they could for community-based organizations, and we can do much better with that. And we can figure out reforms and changes. And I believe the council have heard and seen reports from the Human Service Council, hearing from the city controller that there's been an issue, and we can make changes there to address that. The other thing is, we've talked a lot about data. And I believe, when the city was using 7 measures of reopening, they lacked one major one. The 8th measure should have been tracking disproportionality.
Time expired.
It should have been a part of that. It should have been about more disaggregated data. And they're doing a better job, but we need to look at disaggregated data. And we need to look at mental health, like supporting resilience of individuals and communities, building resilience in informal supports, mitigating barriers to seeking care, and strengthening partnerships between professional care providers and community-based organizations, which means looking back at Thrive and seeing what works and has not worked and improving on that as well. I'll stop there. Thank you.
Thank you for your testimony. I'll now turn it to Medha Ghosh for testimony. You may begin when you are ready.
Starting time.
Hi, good afternoon. My name is Medha Ghosh, and I'm the Health Policy Coordinator at CACF, the Coalition for Asian American Children and Families. Thank you very much to Chair Shulman and Moya for holding this hearing, providing this opportunity to testify. Founded in 1986, CACF is the nation's only Pan-Asian children and families advocacy organization and leads a fight for improved and equitable policies, systems, funding, and services to support those in need. The Asian American Pacific Islander, AAPI population, comprises nearly 18% of New York City. Many in our diverse communities face high levels of poverty, overcrowding, uninsurance, and linguistic isolation. Yet the needs of the AAPI community are constantly overlooked, misunderstood, and uncounted. We are constantly fighting the harmful impacts of the model minority myth, which prevents our needs from being recognized and understood. Our communities, as well as the organizations that serve the community, too often lack the resources to provide critical services to the most marginalized API New Yorkers. Working with over 70 members and partners organizations across the city to identify and speak out on the many common challenges our community faces, CACF is building a common community too powerful to ignore. In the summer of 2021, we conducted a rapid needs assessment in collaboration with the NYU Center for the Study of Asian American Health and the Chinese American Planning Council, over 1,000 adults of Asian, Latinx, and Arab descent living in the metropolitan New York area to assess the current ongoing needs of the community during the COVID-19 pandemic. A report with the findings will be released next month. This report highlights the disproportionate impact COVID-19 pandemic has had on the New York Asian American community that requires an acknowledgement and equitable support and resources to support our communities in ongoing COVID-19 relief and recovery efforts. Our community-based organizations have had to pivot to provide basic needs and resources to our community members, including timely COVID-19 prevention and vaccination information in preferred languages, language for interpreter services to link communities to appropriate social services and public benefits, and food support to support food insecurity. These issues remain largely unaddressed by local, state, and national leaders in the COVID-19 emergency response efforts. I know I'm running out of time, but I really want to emphasize that our major recommendations are improving COVID-19 vaccination access.
Time expired.
Our studies show that Bangladeshi and Nepalese communities are still struggling to get vaccine access. It's not vaccine hesitancy, but just not knowing where to go and having proper information. We also want to request expanding language access and services for COVID-19 efforts and social services, and expanding eligibility, including for citizenship and part-time employment status for benefits, and extending eviction moratorium, and funding continue to support Asian American service community-based organizations. Thank you.
Thank you for your testimony. I'll now turn it to Greg Mihailovich for testimony. You may begin when you are ready.
Starting time.
Okay, thank you, Chair Shulman, Chair Moya, and members of New York City Council. My name is Greg Mihailovich. I'm the Community Advocacy Director for the American Heart Association here in New York City. And as the nation's oldest and largest voluntary organization dedicated to fighting heart disease and stroke, we believe that every person deserves the opportunity for a full, healthy life. And our mission to be a relentless force for a world of healthier, longer lives is more important than ever. A lot of people have touched on this, but the COVID-19 pandemic has underscored the serious gaps in our public health infrastructure because of years of chronic underfunding. Black, Latino, LGBTQ, and other medically underserved populations are more likely to have the chronic conditions, including heart disease, hypertension, diabetes, that may put them at higher risk for COVID-19 complications. And they're also more likely to face these systemic obstacles to good health, such as lack of access to quality care, jobs, education, and housing. And we've seen the devastating consequences that can have in the face of a public health emergency. So a strong public health enterprise that prevents and protects all New Yorkers from diseases, both communicable and non-communicable, requires robust, sustained investment. And as the council begins the budget process for the first time this term, we ask you to prioritize funding and programs that address these systemic health inequities. I'm going to touch on a couple of them really quickly. Increasing access to care means investing in community health centers. These are those trusted messengers, as Dr. Chosky called them. We also think there needs to be sustained investment in telehealth. As council members Moya and Brewer both mentioned, a lot of New Yorkers face obstacles to accessing the telehealth. New York's done a lot addressing food insecurity, but we're still facing nearly 1.4 million New Yorkers facing food insecurity, and we need to continue investing that people have access to healthy food. And living tobacco-free, smokers are more likely to be vulnerable to severe and potentially life-threatening cases of COVID, so we need to continue and expand tobacco cessation programs. Boom. Thank you for your time. We look forward to working with this council to help New Yorkers live longer and healthier lives.
Thank you for your testimony. I'm now going to turn it to Chair Schulman for comments.
Thank you. I just wanted to thank the panelists for your testimony. I've been taking notes while you've been talking. And you know, we can only succeed having you at our side. So we really appreciate it. I know some of you I don't, some of you and all of you I'm hoping to get to know better as the chair of the health committee. And I really appreciate you being here. I appreciate you waiting. You know, we really wanted to drill down with the administration, and we're hoping to do that moving forward, especially during the budget process. And I hope to be circling back with you too to get some questions as we get to that process later on in the coming months. Thank you.
Thank you, Chair. I'm not seeing any other hands, Councilmember hands, so I will thank this panel for their testimony, and we'll move on to our next public panel. In order, I'll be calling on Lily Carino Higgins, followed by Bartana Gurung, followed by Amelia Rose Liu, followed by Jordan Goldberg. Lily Carino Higgins, you may begin your testimony when you're ready.
Thank you. Thank you for this opportunity to testify before you today. My name is Lily Carino Higgins. I'm here representing 250,000 members of 1199 who reside and work in New York City. Our members work in the municipal and voluntary hospital systems, as well as in nursing homes, FQHCs, community-based clinics, organizations, mental health clinics, home care agencies, pharmacies, EMS, and in the New York City jails. COVID has taken its toll, creating workforce shortages in all healthcare industries. The exodus is not due to fear of a pandemic. It is due to working conditions. It is our view that unless steps are taken to recruit and retain a stable workforce, New York City will reach a crisis point in the very near future. The governor is proposing a $10 billion multi-year plan to fund new initiatives and support the industries. The proposal includes funding for recruitment and retention of workers to ensure long-term stability. For example, a $3,000 retention bonus for workers who remain in the field for 1 year, as well as a 5.4% COLA. Most important, the proposal calls for an increase in the Medicaid reimbursement rates that have been stagnant for over 20 years, despite increasing costs. We urge this council to support these initiatives, but we acknowledge that they are not enough. I've outlined in my testimony additional measures that we're happy to work with this council to implement that will go a long way towards stabilizing the workforce. The council can play a major role in the future of healthcare, and we at 1199 stand ready to work and collaborate with you on how to better meet the healthcare needs of all New Yorkers.
Time expired.
We look forward to a more in-depth dialogue. Thank you.
Thank you so much for your testimony. I'd like to now call on Bartana Gurung to testify. You may begin when you're ready.
Starting time.
Good afternoon. My name is Prarthana. I'm the Director of Campaigns and Communications at Adhikar. We are an immigrant women-led worker center and community center serving and organizing the Nepali-speaking community. Thank you, Chair Schulman, Chair Moya, and members of the Health Committee for providing this space. We're often referred to as our community's 911 and 311 line, serving more than 10,000 Nepali-speaking people a year in the city. The community is one of the fastest growing Asian ethnic community groups in New York City and also work in low-wage industries such as nail salons, domestic workers, taxi drivers, and as restaurant workers. We believe that workers' rights is very much a part of health justice. For too long, the struggles and demands of communities like ours, immigrant women workers in low-wage industries, have been rendered invisible. As we reimagine a just and healthy recovery for all New Yorkers, it's essential that the voices and experiences of our community are recognized and respected. 2 years ago, we were in the epicenter of the first wave of the pandemic, and what we see now is that workers are still struggling, returning to jobs that are not protected at high health risks and unsustainable. wanted to share a quote from a nail salon worker member leader, Maya. She shared, "I've worked in the nail salon industry for 7 years and invested so much in my skills as a technician. I feel like there's so much pressure on workers to make sure that salons profit. There are lots of health problems like health and safety problems, and I'm afraid of going to work due to the lack of protections at work. Members like Maya unfortunately face significant economic, health, and food insecurities and report rapid changes in their industries and working conditions. And in response, we're creating industry-specific English classes, workforce development courses, for example, the NICOSH Beauty School with our union partner, Workers United, and with NICOSH, where we utilize workers' rights-based curriculums to train worker members to gain the skills and resources to better negotiate better working conditions for themselves and their peers. To meet the urgent needs of our city's essential workers like Maya and so many others, we hope the City Council will fund CBOs like Adhikar in the FY23 budget. We cannot continue to solely exist and work to survive. We want to ensure that our growing communities in New York City also thrives. Thank you so much.
Thank you so much for your testimony. I'd like to now turn to Amelia Rose Liu. You may begin your testimony when you're ready.
Starting time.
Hi, my name is Amelia Liu, and I'm currently interning at Live On New York as a public policy intern and a public service scholar at CUNY Hunter College. Thank you for this opportunity to testify on Live On New York's behalf today. Live On New York's members include more than 100 community-based nonprofits that provide core services which allow all New Yorkers to thrive in our communities as we age, including older adult centers, home delivered meals, affordable senior housing, elder abuse prevention, caregiver support, NORCs, and case management. With our members who work to make New York a better place to age. Today, we have a platform to emphasize the steps needed to address and recover from the pandemic, which has taken the lives of many New Yorkers, many who were older adults. According to Live On New York's members who serve older New Yorkers tirelessly throughout the pandemic, key challenges include food insecurity, technology access and support, navigating complex systems needed to access vaccines and testing, lack of mental health support, and programs that combat social isolation. In addition to these challenges, it is evident that the pandemic strained the current long-term care system and exposed its inequities. Research shows that older adult centers want to remain in their homes, but the pandemic has already revealed the supports in place are not sufficient for many. In order to tackle these issues at hand, Live On New York recommends the following. The Department for the Aging and the Department of Health and Mental Hygiene should work together to reassess and update older adult center and naturally occurring retirement community capacity requirements. Additionally, restore cuts to DFDA made through the PEG program, including the $1.3 million cut to plan expansion of DFDA's geriatric mental health program. Further expand funding for technology access for older adults. Also, investments are needed to meet home delivery meal demand and case management needs that will result from the termination of the Get Food Recovery Meals program in June. And finally, fully fund and implement Just Pay, including cost of living adjustments for all workers in the human services sector. I know I'm running out of time, but for more details and information, each of these recommendations can be reviewed in the written testimony. Again, thank you for the opportunity to testify today.
Thank you so much for your testimony. I'd like to now welcome Jordan Goldberg to testify. You may begin when you're ready.
Starting time.
Hi, thank you so much for the opportunity to testify today. My name is Jordan Goldberg, and I am the Director of Policy at the Primary Care Development Corporation. PCDC is a New York-based national nonprofit and U.S. Treasury certified community development financial institution. Our mission is to create healthier and more equitable communities by building, expanding, and strengthening access to primary care. Primary care saves lives, improves community health, and is central to health equity. It has been really heartening in this hearing to hear so much about primary care and preventative care. But primary care remains overburdened and underinvested. The role of primary care in public health planning and emergency preparedness has been undervalued, and the failure to prioritize primary care going into this crisis has been felt most acutely by marginalized communities. With support from this council, for which we are very grateful, PCDC undertook research to identify the relationship between access to primary care and the impact of COVID-19. Unfortunately, our research revealed that communities with less access to primary care before the pandemic experienced more COVID infections, severe illness, and deaths than communities with better access to primary care. As Chair Shulman noted, the pandemic also caused the deferral of necessary healthcare, which is leading to a crisis of its own. People are now coming back to primary care with more severe preventable diseases, including more advanced cancers, and a drop in childhood vaccination that could impact children and communities for decades to come. Primary care has a critical role to play in public health crises, although primary care was largely left out of planning and responding to this pandemic. We encourage the Council to consider supporting a thorough review of all types of primary care providers' experiences in the pandemic, including not just health centers, but independent practices and hospital-associated practice, to understand their access to guidance, PPE, testing, and vaccines. We know that ultimately FQHCs were able to access vaccines through a federal program, and we appreciated the opportunity to work with the CDC and DOHMH to survey FQHCs and distribute $6 million of federal grants for vaccine planning and preparedness. But primary care is critical to public health, and we encourage you to support efforts to more effectively include primary care, all types of primary care from the beginning in the next public health emergency. Thank you for your time. Happy to answer questions.
Thank you so much for your testimony. I'm just going to quickly pause and see if there are any council member questions. I'm not seeing any hands, so I'd like to thank this panel for their testimony, and we'll move on to our next public panel. In order, I'll be calling on Sarah Kim, followed by Betsy Morales-Reed, followed by Tony Stores. Sarah Kim, you may begin your testimony when you're ready.
Starting time.
Hello, my name is Sarah Kim, and I'm a program director at Korean Community Services. Thank you, Chairperson Sherman and the Health Committee for this opportunity to speak about why the Sweet Truth Act will cover all menu items in chain restaurants. I've been serving as a lifestyle coach delivering CDC National Diabetes Prevention Program since 2017. I mostly work with immigrants population with pre-diabetes to encourage them to make healthy choices in eating and drinking to delay the early onset of diabetes, from which I found that the majority of the class participants were not aware of nutritional fact, serving size, or added sugar. Moreover, they did not understand the nutritional labels written in English because of the limited LEP. KCS, a fully recognized organization by CDC in the diabetes prevention program, is aware of the severity of type 2 diabetes caused by overweight and obesity. According to the document on the website of NYC Health and Hospitals, trace and the demographic data, the number one condition that COVID-19 patients self-reported was overweight. Many health professionals and nutrition experts have warned about the tremendous burden of sugary drinks having heavy calories without any nutritional value. Thank you, council members, for passing the Sweet Truth Act last year, December 2021, but it's not perfect in making New York healthy. Ultimately, it's not enough to prevent possible high rate of hospitalization and death when we will face future pandemics. Many New Yorkers go to chain restaurants and they'd prefer to order fountain drinks for combo deals rather than buying canned or bottled soda. And they can fill again and again their 128-ounce gigantic cups. Thank you for my testimony, and happy to answer any question. Thank you so much.
Thank you so much for your testimony. I'd like to now welcome Betsy Morales-Reed to testify. You may begin when you are ready.
Starting time.
Thank you, Chairs Shulman and Moya, and all the other committee members for allowing me to present this testimony on behalf of Hispanic Federation. Since the pandemic began, Latinx communities have been hit disproportionately hard. However, this legislative season gives the city an opportunity to fund programs that enact legislations that can enhance health outcomes for underserved communities. Today, we heard about the importance of community-based organizations. The Communities of Color Nonprofit Stabilization Fund has grown to serve over 250 community-based organizations across NYC that work directly in communities of colors disproportionately affected by COVID-19 pandemic. Now more than ever, as we continue to struggle through the direct and indirect effects of COVID-19, it's vital that CCNSF receives funding to address the growing needs of our communities. As such, we respectfully ask for your continued support of the CCNSF Fund with a $7 million budget allocation for the fiscal year 23 budget, which is essential to ensure that organizations that are led by and serve people of color survive during the pandemic and beyond. Hunger continues to be a major problem in our communities and is directly impacting our health outcomes. HF's long-running Lucha contra el Hambre hunger relief initiative provides food to pantries. Over 92,000 Latino New Yorkers in need have been served, close to 300,000 meals via the expanded hunger relief efforts distributed by our network of member and partner agencies and our local restaurant hot news initiative. So please continue to support this vital program. Also, 2 years into the pandemic, and after the onslaught of the pandemic, the need for COVID-19 vaccine outreach and education community of colors remain. Although Latino numbers have gone down significantly in certain age categories, they still have the highest proportion of COVID-19 or COVID-related death rates of any group in the US in every single one of the age categories. However, we know that our efforts have been effective and we must have the resources necessary to continue these
Time expired.
efforts. I've highlighted other important details on mental health and the digital divide for telehealth medicine and hesitancy and services for immigrants. You can find that in the written testimony. Thank you so much for your time.
Thank you so much for your testimony. This concludes our last public panel. Just to check if we've inadvertently missed anyone that has registered to testify today and has yet to be called, please use the Zoom raise hand function now, and you'll be called on in the order in which your hand is raised. Okay, not seeing any hands, so I'm going to turn it back to the chairs for closing remarks. Chair Schulman.
Thank you. First, I want to give a huge thank you to the administration who has worked tirelessly for over 2 years to address COVID-19, a pandemic where New York City has been the epicenter more than once. And an equally as large thank you to all the advocates and community members who took the time to attend and participate today. You are all the experts in the many communities in the city, and we continually appreciate your work. Today further solidifies the need to continue to have deference to those who are members of the most impacted communities as we continue to address the equity issues and concerns the pandemic has exacerbated. I appreciated the dialogue we engaged in today, the clarifications around DOH-MH's actions and plans, and also further acknowledgement of what we must continue to do. Improve data collection so that we can have more informed responses to COVID and its complications in communities of color, older adults, immigrant LEP communities, LGBTQ communities, those with disabilities, and others disproportionately impacted. Hyper-focus on the communities that continue to be the most impacted, and overall continuing to build a more equitable New York. I'm very appreciative of everyone that has participated, and some of the issues that came up that we're going to look into further are primary care, preventive care. Diabetes was a major focus too in terms of underlying conditions. All of the things that we've spoken about today, we will continue to move forward and study. And also I look forward to reading all of the testimony of all the advocates and panelists here today. And with that, I want to turn it back over to our moderator.
Thank you, Chair. And I'm going to turn it to Chair Moya for closing remarks.
Thank you. Thank you so much. I just want to reiterate thanking the administration and, of course, the commissioner for taking the time to meet with our committees and answering our questions. There's definite follow-up that we have to do, but I thank him for taking the time. And I also want to thank my co-chair, Chair Schulman. Thank you so much. Congratulations on your first committee hearing. You did great as always. Thank you so much for bringing a lot of the insight and passion that you have for the overall health of the city of New York. We truly appreciate it, and we're very grateful to have you. And also to my colleagues, members of both committees, we thank you for participating today. And a big shout out and a big thank you to the staff, to Harvani. Thank you so much for moderating this and helping me and Chair Schulman look good and make it look easy. Thank you to you. Thank you to Sarah Liss. Thank you to M. Bulkin. Thank you to Lauren Hunt, to my Chief of Staff, Megan Daddio, and to Carolina Valencia from my office. We have a real opportunity to take the learnings of the past 2 years of the Omicron surge to address the inequities and protect the most vulnerable populations from COVID-19 and any future pandemics. And as we move forward, we need to continue to work collectively to make information available in language, in cultural relevance, and in trusted ways. That is about making sure that we're investing in primary and preventative care, investing in the tools that will protect us from COVID. This is about making critical and timely resources accessible and ensuring that no community, no neighborhood is left behind. And this is how we can build a resilient communities. Our recovery is incumbent on truly representing and serving the population that make up this city. So thank you for that, and thank you for all the panelists. Thank you for your patience, and thank you for participating here today. This meeting is hereby adjourned. Thank you.
The hearing is done. Thank you all so much.